for the Synergy 17 webinar on the topic Obstacle Collect, Timely Action, Teamwork and Survival. Before starting the webinar, we will have a prayer.
शुभं कुरुत्वं कल्याणं आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणं आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्नमोऽस्तु ते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः.
It is privilege to introduce Dr. Monica Singh. Dr. Monica Singh is President-elect Bhopal Obstetrics and Gynecology Society. She is founder-president of IFSOPAP chapter of Bhopal. She is national executive member of ISAR. She is joint secretary joint treasurer of MPIAG. She is coordinator of Foxy Infertility Committee. And also she is convener of ISAR Perfection Series, Foxy Symbiosis Series, and the present, the Synergy Academic Club. Over to Dr. Monica Singh.
Thank you so much, Dr. Vishal, and for always that kind and enthusiastic welcome. I am just a humble coordinator. The stars are all in front of me, and these are the faculties and the delegates who make Synergy what it is today. Because we will be completing in April 26, we will be completing 3 years of continuous academic webinars throughout India, which have been appreciated far and wide, not because of the webinars itself, but because of the quality of academics that we bring to your doorstep in the comfort of your chamber, sitting at your desk, watching on your computer with a cup of tea, talking to us, interacting with us, and even telling us whether you want to speak next in our program. So I welcome you all with folded hands. And the MS Synergy Club is this time is proud to collaborate with Rewari OBGY Society from Haryana and Gwalior OBGY Society from our own Madhya Pradesh, and it has been awarded 4 ICOG points. Today we will be talking in episode number 17 on what a havoc obstetric collapse can bring, but at the same time, if we have timely action, instinct, reflexes, teamwork, and survival, the will to survive, we can save the mother and baby both. We have today a very wonderful program in front of us. We have 2 talks and a panel. Can we walk you through the program, Dr. Vishal? This is the program which we have in front of you. We will try to cut short the fringes and bring you straight to academics. The first talk is by none other than Dr. Jyoti Bindal Madam, the stalwart from Madhya Pradesh, a great teacher and a leader, who will be speaking on the causes, recognition, and initial response set to obstetric collapse. Next, we have a wonderful talk by another great speaker, Dr. Binu Kushwaha Singh. She is young, as far as age is concerned, but very good in experiences in explaining, a good author, a good clinician, very dynamic person. And she'll be talking on resuscitation in pregnancy and perimortem cesarean delivery. And then we have, real life scenarios put together in a panel discussion where multidisciplinary approach to obstetric collapse will be discussed through personal experiences of all the panelists, especially our moderator and co-moderators. The moderator is Dr. Mitra Saxena. She will be helped by a co-moderator, Dr. Padma Yadav. And we have experts, Dr. Binu, Dr. Juhi Agarwal from Bhopal, and a galaxy of panelists. Now I will come back to our program and our dignitaries. Please bring me the first slide. So we have amongst us a very, very honored and respected chief guest, Dr. Preeti Kumar Madam, who is Chairperson, Maternal and Perinatal Committee of CEPHOC. Madam CV, please. Madam CV is huge, elaborate, but I just want to speak 2 words that my baby steps into the huge organization that is the Federation of Gynecologists and Obstetricians of India. It started with very hesitant steps, but Madam has handheld me, corrected my mistakes, and always acted almost like a mother and a mentor to me. So I have huge respect for Preeti ma'am, and she is the one person I can call early in the morning and call her for any problem, and she'll always solve my problem for me. So thank you, madam, for everything. Besides being very active in CEPHOG, she is the flagship leader of the Manyata project. She's been because this has come because of a chairpersonship of Safe Motherhood Committee, So she has spread this message far and wide in all corners of India. At present, also she's in Orissa and talking to us from her hotel room. She so committed she is to the cause. Madam is also the Joint Secretary of India Gestosis Chapter and committee member of MFM Committee of AOFOG 22 to 24. Madam has held various academic posts and conducted wonderful conferences all over India, especially in the grand state of UP, where she has been the star of Narchicon, UPCOG, AICOG 2020, Lucknow, Gestosis, IAG, and ZYF. Madam has also held a very important post of VP of Lucknow OBGY Society from 20 to 22. We welcome you, ma'am. And I think without wasting time, I would just like to have few words of wisdom from you and your blessings.
Thank you so much, Monica. And at the outset, let me thank you and Randhir for this creating this synergy club. I have been observing this club for a long time, and the quality of programs that you conduct is really very, very good, and it's very well accepted by everyone. And today, I want to congratulate Rewari and Gwalior Ops and Gynae Society for joining hands with Synergy Club and for this very important program on obstetric collapse. And you have selected I think the best teacher, Dr. Jyoti Bindal madam, whom we have high regards. And she's a wonderful, always helping, and the kind of experience she has, I think this will be very, very useful for the participants. And I really feel very, very proud when I share the dais with the people like Dr. Shashi and Dr. Rachna and Archana and Rita. All of them are doing wonderful work in Foxy, and we are doing as much as possible for women's health. And Monica, I have witnessed the kind of commitment you have for Manita, because I was the one who pushed you in Manita, and you became the trainer, and then your facility was also you were very upset initially, then you got convinced, and then your facility was also accredited with Manita. And the second program that we did was on alternate birthing position at Bhopal. That was also a very new initiative and really wanted to take it ahead, but we are looking at the funds. So thank you everyone and all the faculty members who have joined today. I'm sure that I'm also here for one of the reasons that women don't go in obstetric collapse. So everything is taken well care of. Our president, Dr. Sunita, is also working towards preconception care. That's also the foundation for the healthy pregnancy. So together in our own domain, we are doing best whatever possible. So I think Dr. Mitra Saxena is also one of the a very experienced faculty. I think she will conduct the panel very nicely, and the panelists, I think they will also share their experiences. So I'm traveling from them since morning to come to meet Dr. PC sir, because we wanted to spread Manita in Odisha. But this speaker will be on, the Zoom link will be on, because I want to listen to Dr. Jyoti Bindal madam and also the other speakers and the panel moderation. So thank you so much. And just one more request, Monica, since you're doing such a lot of work, good work on webinar, please keep few sessions on hands-on training as well. Take one topic and then just demonstrate how it is done. That will also be very well accepted in your synergy club. So that's my suggestion. So like if you're taking a peripartum cesarean or hysterectomy, whatever you are taking, just put that as one of the topic and then show how it is done and what are the challenges and how you go about it. So that will also be very much accepted, and this is also way of teaching people. So that's my humble suggestion. If you just think over, hands-on sessions would also be very, very useful for the participants. So thank you everyone for inviting me as a chief guest. It's a great honor for me, and I would love to be here again and again for the Synergy Club. All the best, Monica and Randhir.
Thank you. Thank you, Preeti ma'am. Thank you so much. And those suggestions are really wonderful. In fact, we would like to now inculcate more and more of videos and more of practical demonstrations, so that like the viewers now get to the next level. And madam has herself in the ABP program, I remember everything, the team was so competent. They actually, demonstrated every action of the laboring mother. how she will sit on the balloon, how will she have a chair birthing. Like it was so beautifully demonstrated that you want to, accept and teach your staff that very moment. So, madam, that can be very easily done. And, we have such great team with us. And I'm so fortunate that I call anybody and nobody says no. So I'm sure we'll take it to the next level. Thank you so much for joining, madam. Thank you for your
Thank you so much. Thank you. Great honor.
much, ma'am. Thank you, ma'am. Taking the program forward, we move to our guests of honor. Our guests of honor are the ones who are, there to bless us, to lend a lot of glitter and illumination to our program because of their wisdom, because of their personality, charisma, and the amount of work they have put in the field of obstetrics and gynecology. So we have Dr. Shashi Bala Bhosle, ma'am, with us, very lovingly called madam from Gwalior. Madam has recently been the founder president of the Gwalior Menopause Society, and we congratulate madam for that because
Thank you.
we congratulate madam for being the founder president, and she's also the immediate past president of GOGS 22-23. Always a very dynamic and electrifying sort of personality. I mean, you lit up all the places that you go to because of your sheer enthusiasm and vitality. So, madam has also been very active in the IAEC committee and a lot to look up to in the Public Health and Family Welfare Department of Government of Madhya Pradesh. Of course, Bhopal is the hub, but madam is holding the fort in Gwalior. Madam, the stage is all yours, and we are honored to have you as guest of honor today evening.
Thank you, Monica. Thank you so much for those loving words. Actually, what you see me, first let me wish my teacher, Dr. Jyoti Bindal, ma'am, a very, very good evening, because she has a lot to in shaping of me as what I am today. Because I have worked with her, I think maximum, Rita, I must have worked maximum with her. So I can proudly say she's my mentor. And Monica, as you say, I have been in public health and I have not been in cities. I have seen the rural side of obstetrics. And I was very lucky. I was attached to the Urban Family Health Center, which was under the medical college. And there we had all normal deliveries, and we had to anticipate in advance that all in advance we had to refer them. So that's how I got all my clinical knowledge right at the ground level. So that gives me, I think, one edge, because if you work in Kamla Raja or where tertiary centers, you are safe, but there you have to take decisions, and I was lucky right at the periphery. So I learned a lot from my patients, and to this date there was no calamity or something that will give me a guilty conscience till date. So thank you so much. And Dr. Preeti, I must say, she's the super foxian, and what she is doing is what every gynecologist or obstetrician should do. That is the base root cause of all our miseries, maternal mortality. So that is what we have to, and it is very bad that we are at the top rung of this matter. We are leading, I suppose, no? That Rachna, I think, can detail it in a better way, because SDG goals are not filled. So that is one sore point with our MP. So that we have to rectify. And thank you so much for giving such an important topic. And obstetric collapse, before the patient collapses, the obstetrician collapses. So that thing has to be taken care of. We have to be more assertive. And ignorance is no more a bliss. You have to know what is to be known, and you have to anticipate. And those HRP clinics, what we have been conducting all these years in our public health and all, and everybody is doing it now. Even the private sector has joined us. So that gives the real good idea what we can anticipate. So anticipation is very important. You should not be caught unawares. And I will not take much of your time. And thank you so much for giving this topic to all of us. And I'm waiting to listen to Madam and Binu, and of course the panel by Mitra. So, and Rita, welcome. Rita is my friend from the classmate from before we were in medical. And so over to you, Monica. Thank you for calling me here and call me again and again in all your synergy things. Thank you.
Madam, you are our team. You are part of us. So you're always welcome, madam, anytime and any.
Yeah.
And I
Yes.
will wait for Rachna ma'am to join because she is yet to join. She has also got lots of commitments because of her post.
Yes.
The government of Madhya Pradesh. She's holding multiple departments and
Yes.
huge programs in KNK Hospital. She keeps a regular discussion with us that how to arrange IUI lab and how to arrange. So I think she's busy. She'll join very soon. So we move on to our special guest for the evening. Before I move to special guests, I extend very good evening, warm good evening greetings to Mitra ma'am, who has joined. And welcome, madam. She's also, neck deep in all her election campaign, and yet she took out 1 hour for the panel. And before that, she has given us lots of slides and videos to, go through. Our special guests for the evening are the presidents of the two societies who have collaborated with Synergy this time, Rewari OBGY Society, headed by President Dr. Archana Yadav Madam, and Gwalior Obs Society, headed by Dr. Rita Mishra Ma'am. Dr. Archana Yadav is a very senior obstetrician gynecologist from Rewari and HOD Gynecology Department of OBGY Civil Hospital Rewari with a vast experience of around 3 decades. She has special interest in high-risk pregnancy and infertility. Welcome, madam. A few words from you, which will encourage us to move ahead.
Thank you, Dr. Monica, for inviting me or for having me for this wonderful webinar. Thank you so much.
Thank you, ma'am. Because we were very excited when when Mitra ma'am was there, the first thing I asked was we want to do it with Rewari only. Because, we wanted to get to know the society better and have a lot of panelists and involvement from there. And it would make Mitra ma'am also happy. So when
Definitely.
madam
This
is
is a
having
very nice way of interaction with Bhopal and Madhya Pradesh and Gwalior. So I am.
Yeah, so I'm also part of
Mitra is from Gwalior only, I think. Some roots she has in Gwalior.
Madam muted up. Mitra ma'am, you're
My
muted.
father is GRMC.
Ah, that's it. The secret is GRMC.
Madam,
Yes.
GRMC में सबके कोई ना कोई roots हैं. I don't know. I think everyone I have talked to in anywhere in India or abroad, they have some roots in GRMC. I don't know how it is possible, but वो connection मिलता ही है, madam. And this is a truth, this is a fact. I've seen it. So thank you for joining, Archana ma'am. And now I would like to extend a formal welcome to President GOGS, Dr. Rita Mishra ma'am, who has recently taken over the society. She has started the work in the society with a big bang with her secretary, Dr. Anju Verma. Because daily in our MP group, we are seeing the huge amount of work that Gwalior Obs Society is doing day in, day out, and Menopause Society being founded by Pam Madam. So I think Gwalior is all the way to the front of the race. And Madam is also very senior gynecologist from the city of Gwalior, historical city of Gwalior. She apart from her huge experience in the department of OBGY, GRMC, as well as Kamla Raja Women Hospital, she has also been active in the Public Health and Family Welfare Department of the government of MP last 35 years. She has held multiple posts in Gwalior Obs Society, very active as a president. And we welcome you, ma'am. She's the recipient of Gwalior Chikitsa Ratan Award, Corona Warrior Award, and is also a writer, an author, lekhak. So we welcome you, ma'am. And we would love to have a few words from you and maybe 1 or 2 lines of what you have written.
That's not on, that's actually on the subject only. Like whenever I go to give talk on menopause and I write the poems about the menopause. Whenever I went for the adolescent talks, then I write the poems on the adolescent talks. They are the big ones and I don't remember actually. I have to take out these papers presently, then I can say. They are the long, actually, I am taking all the points of the adolescent care and all the points of the breast carcinoma and menopause in that poem. I am not a writer, in fact. बस कुछ तो भी tidbits type का हो जाता है and that makes a poem.
मैडम एक सजेशन है
जी,
ये
yes.
पोएम्स की कंपाइलेशन कर दीजिए ये बहुत ही नायाब
collection hoga, because
Sure, I will do. I was thinking of doing that. One of DDMP told me that we will call you because I was going there for this talk on the menopause, and then I told them about all this, and they said कि हम आपको कभी सम्मेलन में बुलाएंगे as a doctor कभी मैंने कहा I am not a poet actually, but I will do that. They said me to do this, and they will publish this in the papers and everything. So I will send to you, ma'am. Definitely, I will send to
sure.
you. So first of all, thank you very much, Synergy Club convener, Dr. Monica Singh and Dr. Randhir Singh for making part of this wonderful webinar. The topic obstetric collapse is really of crucial importance. So I am really feeling privileged to be here amongst with such distinguished speakers, such learned speakers as Madam Bindal and Dr. Juhi Agrawal, Dr. Vinu Kushwa. Madam Mitra Saxena is there also. And such enthusiastic audiences are also here. We know that mere imagination of a patient collapsing on operation table or in labor room. So we all get petrified and panic stricken. But when it actually happens, we lose our nerves and we do lot of mistakes while dealing with the situation. And this is happening especially with the beginners. First time they are dealing with this such situations. So I think such type of the information, like such of the webinars, they should be made mandatory for each and every obstetrician to get the knowledge of call for help and a clear cut line of action to deal with such near death experiences. It's really mandatory for all of us, especially for the village doctors who are dealing with the CSCs, district hospitals, and all, because during referral only patients are dying. Before coming to the medical college, patients are dying on the way. So it's really a very vulnerable subject. Thanks, Dr. Monica, for taking this subject. We know that Madam Bindal is mentor of many of us. We all are having high regards to her. She is our first speaker. So definitely her insights are going to be very helpful to us and very phenomenal to all of us. The
Hello.
other speakers are also very remarkable ones. I really give my highest regards and greetings to our chief guest, Dr. Preeti Kumar, to Dr. Mitra Saxena, to all the chairpersons, to all the moderators, to all the panelists, and to all the chairpersons. And I am damn sure that the presence of such remarkable brains on this platform is really going to help us a lot to delve us into the intricacies of this subject, obstetric collapse. Once again, thanks to all, greetings to all of you. And Dr. Monica, once again, thanking me to making me part of this webinar. Thank you.
Thank you so much, Rita ma'am. And those are very, very encouraging words. And I also feel so excited because just now when I talked to Bindal ma'am, she said, Monica, I was tired of becoming chief guest again and again. Now today I'll be speaking on my favorite subject. So that encouraged me so much. And we are
That's our favorite subject. That's our favorite
so,
subject.
so I thank my co-convener, Dr. Randhir Singh, who is always, in front of me, behind me, by my side in all my activities, managing committee member of ISAR, and my 4 beautiful coordinators. You must have talked to all of these lovely girls all the time. Purva Bhatkur, Assistant Professor GMC Bhopal, Nanandini Singh Bhati, Assistant Professor GMC Bhopal, Shweta Agarwal, IVF Girl, Ashoka IVF Care Bhopal, and Shikha Gupta, Director, Deep Shikha Hospital, Bhopal. And, all of them are renowned in their fields, very, very hardworking. And the middle of their work, they do this work for me, with me, and for all of us. Thank you so much, all 4 of you. I request Dr. Purva to start session number 1.
Thank you so much, ma'am, for your kind words. Now, moving to our first academic session, that is on obstetric collapse, causes, recognition, and initial response. We invite Chairperson Dr. Veera Lohia, Madam, Dr. Anju Verma, Madam, and Dr. Monica Singh, Ma'am. Dr. Veera Lohia, Madam is presently Vice President, Gwalior Menopause Society. She is a very senior gynecologist and Director of Janak Hospital, Gwalior. She held various executive posts.
Purva, please move ahead. We'll save time.
Okay, ma'am. We welcome you, ma'am. Next,
Thank
we have
you.
Dr. Anju Verma, Madam. Madam is presently Secretary of Gwalior Obs Gynae Society. She's a very active member and infertility specialist at Dr. Verma Hospital and Fertility Center, Gwalior. She is presently chairperson MP Chapter ISAR, organizing secretary of National ISAR 2023 Bhopal. She has been credited for delivering first IVF baby, first ICSI baby, and first egg donation baby in Gwalior Chambal division. We welcome you, ma'am, to chair the session. Thank you, ma'am.
No need to
Next, we
introduce.
have our own Dr. Monica Singh, ma'am. Madam is presently President-elect of Bhopal Ops Gang Society.
Thank you.
So,
Thank you. Yeah.
I hand over the session to our chairperson to introduce our speaker, ma'am, respected Dr. Jyoti Bindal, ma'am.
Okay. Can you play the TV? Yeah, Dr. Bindal, we have been associated with her since a long time. Though I'm not from here, I've done my MBBS MS from Jaipur. But after getting married and being, she is mentor and guide to me also as for other students. And I have worked with her a lot in MPOGs also. I was secretary with her. I would say she has been a very good administrator. She has taken post here also in GRMC Gwalior, and there also she was dean in Indore Medical College MGM, and then she was vice chancellor of she is vice chancellor of Aurobindo University also, and she has received many awards. And one of the awards I remember very vividly gave Foxy Shiromani Award. And she also received last year a fellowship of Royal College, RCOG that is, and she has been member of many societies, and she was also member of COVID technical. Hello.
Can we just skip it, Veera? We all know. Come on.
Ma'am, we are so delighted to. I am delighted to chair your session, ma'am. Would like to hear from you, ma'am. Welcome, ma'am.
Monica will like, can I share my screen?
Yes, ma'am. Please, ma'am.
We were going to do a trial run, but you know, my earlier meeting overran and.
No, madam, you can do a trial just now. अपने घर वाली बात है, madam, ये तो.
So,
जब तक आप ट्रायल रन कर रहे हो, मैं डॉक्टर ज्योति को नमस्ते करना चाहती हूँ. It was such a pleasure to meet you, ma'am, in Indore. और although मेरा असाइनमेंट तो शाम को है, बट मैं अभी से लॉग इन करी हूँ क्योंकि मेरे को आपसे मिलना था, आपका सुनना था.
मैडम अभी आया था, स्क्रीन पे आया था मैम आपका प्रेजेंटेशन. Yes.
It's such an important topic. We all want to listen till the end.
And we can see the screen. Make it, please make it full screen.
Let's make it full screen.
Yeah.
Full screen नहीं है अभी.
अभी मैम normal view है. It is the
by slideshow.
Okay. But in the meantime, you know what I want to say, why I said yes to Monica. One, the person, as she says कि उसको कोई ना नहीं करता, which is a true. I also couldn't say. She was one big reason I said, and as I mentioned to her, अभी full screen है?
नहीं मैम अभी नहीं हुआ.
तो
just make it by slideshow.
हाँ मैम slideshow पे डाला है हमने.
मैम slideshow से हो जाएगा.
slideshow पे नहीं है.
मैम
मतलब हमारे इसमें
मैम साइड में कॉर्नर में ऑप्शन आता है slideshow का.
मैम ऊपर एक बार है जिसमें फाइल होम इंसर्ट डिजाइन लिखा हुआ है, उसमें आपको स्लाइड शो पे जाना है. ऊपर एक बार है मैम टॉप पे.
Don't see that. We just
ये ना एनेबल एडिटिंग तो नहीं करना इसमें. देयर इज अ प्रोटेक्टेड.
So the reason why I said yes, and as I mentioned to Monica, पता है जब अपन सीनियर हो जाते हैं, मतलब अकल में नहीं तो भी अपन एज में हो जाते हैं या पोस्ट में हो जाते हैं. So all you are ended with everybody asking you to be either the chief guest or guest of honor. So when Monica said, "Would you like to speak?" I really jumped even without preparing and without. Layouts and options में देखो. Can you
इसको
see the
full
full
screen नहीं हो पाएगा मोनिका?
Ma'am,
Monica, need your help probably. I don't know. We can't see. Slide control.
can the technical team help? Dr. Vishal?
Madam only has to do this. Madam, on top right corner, you can make a click the box so it will be full screen first of all. Or below also there is option of slide.
ये नीचे है ना, ये जो स्क्रीन है फुल स्क्रीन नहीं दिख रहा?
नहीं, वो तो हमारे स्क्रीन के हिसाब से तो हम ये
क्या होगा मैम, आप करिए क्लिक उसको।
आप इसको डबल क्लिक करो। नहीं
डबल नहीं, इसके साइड में मैडम जो सिंबल है।
मैम आप पूरी पीपीटी को बंद कर दीजिए, फिर आप अपने स्क्रीन पे पूरा फुल स्क्रीन खोल के फिर शेयर कर लीजिए। आप इसको क्लोज कर लीजिए, फिर आप अपने डेस्कटॉप पे पूरा खोल लीजिए, फिर स्क्रीन शेयर पे लाइए, शायद तब हो जाए।
हाँ मैडम, यस मैम, वी हैव इनफ ऑफ टाइम, नो प्रॉब्लम।
And then I also wanted to talk about my Rewari connection, why I wanted to be here, and Madam
So
Mitra
sweet.
knows. So Bindals are originally from Rewari, and well, you know, it was when I came to know कि इन लोग साथ में Rewari society है, so I said this is one chance to go back to the roots.
मैडम,
So
पता नहीं था ग्वालियर में रेवाड़ी मैंने आपके लिए कर दिया।
हो गया
Full screen.
Okay,
रेवाड़ी
perfect.
कनेक्शन हो गया।
So coming to the topic, and I'm really very thankful to Monica and the entire organizing team for giving me this chance. Obstetric collapse actually is a very, very vast subject, and it's humanly impossible to do justice to all the causes, recognition, and initial response. So I have tried to briefly touch, because everybody sitting here today in the audience is also quite senior and is very, very experienced when it comes to obstetric practice, and there is not a single obstetrician who has at some point of his or her life not experienced those moments of panic. As I used to tell my PGs, anybody who's not perforated a uterus has not done a DNC. So similar way, anybody who says that I've never experienced a collapse will not be true. Although I've listed all the causes of obstetric collapse, I'm not going to be delivering the reasons or details of all of them. But of course, most of us do see postpartum hemorrhage as one of the major causes. So that is the cause behind it is hypovolemia. Then hypoxia, because the oxygen supply goes down. Electrolyte imbalance is actually a very, very major cause, and this is so often overlooked. Thromboembolism doesn't happen very often, but it is also a cause for collapse. Toxicity of medicines is another cause. Eclampsia, even today, it remains the major cause for maternal mortality. And I'm very sorry to state that Madhya Pradesh as a state is #1 in maternal mortality. We often blame unknown and unpredicted deaths to amniotic fluid embolism, where actually it happens very rarely. But uterine rupture, all of us who have worked in government hospitals and where we get literally conveyor belt system for deliveries, have seen so many cases of uterine rupture and uterine inversion. We have had very harrowing experiences with uterine inversion cases. And I remember one of the incidences when we had a uterine inversion, and as a young assistant professor, I thought it was uterine inversion, but my senior for some reasons was saying that it's looking like it was a case of chronic inversion. To her, it was looking like a case of fibroid which is coming out, and of course, we took her into OT and we could actually save her. I have just taken 4 major causes, because this is what probably most of the cases will come in this category, and they can be trauma, hemorrhagic shock, septic shock, and eclampsia. And they can be at any time. They can be antepartum, intrapartum, or postpartum. when we talk of trauma, we have to know the level at which the pregnant uterus would lie at that particular time. And with that, we can see, suppose, for example, suppose if it is below 12 weeks, then any blunt injury on abdomen will not be a cause of this shock. We have to think of other reasons. Most of the cases of trauma are seen either in the vehicular accidents or domestic violence. I've seen a lot of cases of domestic violences where the uterus was somehow injured and the patient went into shock. Before we go into the causes, it's very, very vital for us to know what are the normal parameters and how they change in pregnancy. Please remember that in third trimester, there is a little rise of heartbeats, but more important, till second semester, the blood pressure level, normal blood pressure level is 90/60. However, in the third trimester, the systolic blood pressure may go up to 130. So the normal range for a normal non-pregnant patient is not the range for a pregnant patient. When we talk of trauma, there is no difference in managing a pregnant patient versus a non-pregnant patient. We all have to remember the basics of maintaining airway, maintaining that she's breathing, the circulation. The only thing which makes a difference is that intubation is very difficult in late pregnancy. Normally also she would have a faster respiratory rate and there would be a maternal hypotension, as I just now described. But what is very, very important is that sustained systolic blood pressure below 90 will cause a decrease in placental flow, and that's why we have to act very fast. And the only thing is you do not need to confuse this lowered blood pressure with the supine hypotension syndrome, which is very common. And as soon as she stabilized, the fetus has to be looked for. As long as the fetal monitoring is done and everything is all right, there's nothing you need to worry. If I talk of puerperal sepsis or septic shock, in the first hour, all you need to do is oxygenate, oxygenate, and oxygenate. That's a very, very important point. Remember, when a patient is diagnosed with sepsis, and trust me, many of us will straight jump to antibiotics. I would say that we need to load her with good IV fluids and oxygenate her. As soon as we see that her blood pressure is coming up, her oxygen is 90%, and she is coherent. Mental status goes down if there is a septic shock. The urine output also has to be looked for, and we need to see the urine output very carefully, especially in the cases of septic shock. And now we come to the king of the reasons, preeclampsia, eclampsia. Most of the mild cases will not show any symptoms. There could be proteinuria, but what puts it apart is the reflexes. They become very brisk. I mean, you have to try it on your milder cases. What worries us are the severe or fulminant cases where the patient may only report to you with just headache or blurred vision, sometimes epigastric pain. Edema has to be differentiated from the normal edema of position. So there's always, many times I would say, a facial edema as well. Patient is very jittery and breathless. The blood pressure, of course, is high. Proteinuria is there. So if it's a case of fulminant preeclampsia or eclampsia, the first thing one needs to do is ask for help. That is the first thing if there is any convulsion in a pregnant woman. Again, we come back to ABC, oral airway. We have to prevent obstruction by tongue and put the patient in left lateral tilt position and put her on bag valve and mask oxygen. Circulation has to be maintained. Remember, no bolus has to be given. I've just identified the gauge by its color. Our young residents need to know, दूर से दिखना चाहिए कि कितने gauge की needle है. We have to put at least 2 IV lines. We have to catheterize the patient. We have to put her into left lateral positions. And then we have to send her blood for various tests. The side rails of a bed have to be raised because this patient is, there's a good chance that she may fall. And of course, the drugs, medications have to be started. A small note, because I'm not going to be going in the details of all the treatment. One thing very, very important, which many people miss, is that the first IV dose has to be given over 20 minutes. It has to be diluted. And after this, the intramuscular dose, 2.5 grams in each buttock. So in the first hour, do not exceed 9 grams. Different theories, different books say different dosage. And I would insist that one should not exceed this. Very rarely, within 15 minutes, you may have to repeat one dose if convulsions recurs. 2.5 grams is the upper thing which you can give. But before repeating, the respiration has to be checked. The patellar reflexes, the urine output, all these have to be checked. I would again insist that magnesium sulfate can never be given rapidly IV. It may lead to respiratory failure. Calcium gluconate is the antidote and it has to be given IV over 10 minutes. Whatever magnesium sulfate vials we get are always 50% MgSO4, and so you have to take 4 grams of it and dilute it. This reminds me of an incident. There was this patient who was being given diuretics, and like a normal person, like a normal senior consultant taking the round, I just told my PGs, make sure कि इसको potassium depletion नहीं हो जाए, so give her potassium. I did not specify the route, assuming that she will give pot chlor liquid or something, which was the norm those days. I think the team must have barely walked out of the labor room and gone to the next ward, and suddenly we get cries for help. We rush back. We find that the young PG has given potassium IV. She had a stoppage of heart. You know, we could actually revive her. That I consider one of the biggest achievements. But this also shows how specific we need to be in our instruction, especially in labor room. The hypertension, of course, has to be controlled. The drug of choice is labetalol, but if it's not available, then nifedipine. In these cases, the sublingual route should not be used, and we should make sure that the diastolic blood pressure does not fall below 100. The shock which many of us see in the labor room is the hemorrhagic shock. Remember, if a patient is in shock and the pregnancy is not beyond 28 weeks, she could be a case of early ectopic pregnancy, an incomplete abortion, or a molar pregnancy. But after 28 weeks, the first thing we need to think of is placenta previa. We should avoid any pervaginal examination, but if there is tenderness, then one has to think of abruptio placentae. And if there is sudden cessation of contraction, suddenly patient is not getting those painful contractions, then you have to think of uterine rupture. And I remember, I don't know Rita if she remembers, but we were together in the labor room when in front of our eyes, this patient who was having very strong contractions actually became very still and said, I mean, you know, she was not feeling the contractions, and without even doing any other examination, we just rushed to the theater. And of course, we need to give fluids and rapidly transfer her to the senior obstetrician. As I said before, pelvic examination should not be done. In case of concealed hemorrhage, there may be no external bleeding, but patient may still be in shock. I just now mentioned uterine rupture, which is again a nightmare. The patient will have fall of blood pressure, patient will have cessation of labor pains. So stop oxytocin, stop thinking about vaginal delivery and transfer her to the theatre. Of course, again, ABC is a standard thing, but give her oxygen, give her IV fluids, do a bladder catheterization. These are the basic fundamentals for managing a case of uterine rupture. In any case of hemorrhage, we call PPH as predict, prepare, and handle. The first one R is Goldner, and the 4 T's have to be seen. And as you can see, the atonic uterus causing PPH is seen in 70% of the cases. That there could be trauma as a cause. So it would mean cervical, vaginal, and perineal laceration. There could be hematoma. Sometimes hematoma is discovered much later. She's delivered vaginally, her blood pressure is falling, and there's no bleeding, but the hematoma is increasingly present. Inversion uterus, rupture uterus, then tissue related. So retained tissue or invasive placenta. In fact, these days I'm writing a chapter on cesarean scar ectopic pregnancy, very interesting. And then of course coagulopathies, which are present only in 1% of the cases. We already talked of atonic uterus, but we have to make sure that we identify it. It is within 24 hours of birth, actually atonic happens. And you know what is the most important cause of atonic? You are already giving an oxytocin, and the minute she delivers, you stop it. Never stop it. It has to be gradually tapered. One has to look at for flabby uterus, subinvoluted uterus, and we all know how to prevent atonic uterus, and that is by active management of 3rd stage of labor. Oxytocin have to be given after birth of baby 10 units. Placental removal has to be by controlled cord traction and uterine massage. So these are the steps by which you can actually avoid atonic uterus by 60%. The emergency kit should always be in the labor room, and in the new guidelines, we have prepared those trays for labor rooms where there's a specific tray for PPH management. So the kit should have all these listed things. And as I said, prepare, predict. So based on history, based on examination, you need to make sure that the help is available, vitals are monitored, oxygen, wide bore IVs, bolus, and continue this till you stabilize the patient. Then go in for the blood grouping because you need to organize the blood. Then various oxytocics. And please just look at this order of administration. The first drug to be given is oxytocin, then of course misoprostol, Mithergin or ergometrin has come now number 3, which used to be number 1 in our student days, and of course carbaprost. I've just tried to put all the types of management in one slide. Bladder must be empty. One thing which is overlooked by many of this, even senior people, they forget to catheterize, massage the uterus, press it between 2 hands, what we call bimanual compression, of course, then aortic compression, NASG, and balloon tamponade. I'm not going to go on in this details of this chart. This is just to tell you the dosage, and important thing is caution. So with ergometrin and with carbaprost, one has to see this. Again, a very funny and very interesting case. And guess who was getting delivered? what's that latest actor, Karthik K?
Karthik
Aryan.
Karthik Aryan.
Mala was getting.
So this was Karthik's sister I'm delivering. I'm in a nursing home and she has a bout of PPH. And who all are there? I'm there, the nursing home owner is there, and the husband who's working as a pediatrician and as a help. So I tell him, Doctor Sahab, quickly prostatine लगा दो. अब फिर वही, आपने रूट तो बताया नहीं, आपने डोज तो बताया नहीं, डोज तो चलो ठीक है प्रीफिल्ड वायल. अब उन्होंने लिया और आईवी straight. Imagine, I think I went into collapse rather than my patient, but again, we could manage. But these are certain incidences one can never forget of obstetric collapse. So the first thing you will always see is shout for help. That is the first thing you need to do. Monitor the vitals, start the IV line, give fluids, give oxygen. Please look at the rate of oxygen, at least 6 to 8 liters per minute. Catheterize, massage, monitor the vitals, check if placenta is out or not, and then follow the protocol. As I said, any hemorrhage will lead to shock, and all the basics of shock management have to be done. I'm not going to repeat, but we all know these steps, and the only thing which is added in this slide is replace 3 times the estimated loss, and you can think of IV tranexamic acid things there. The second cause of, the first was atony, but the second is trauma. Now, trauma means it can be an injury to cervix, vagina, perineum. You can see, you can immediately make out uterus is well contracted, but she's bleeding. So after ruling out atonic, which is the maximum, I said 70% of the cases, then you first give her the fluids and then examine the perineum. Make sure what kind of tear it is. If it is 3rd or 4th degree, you need to shift her to the OT or call for anesthetist as well as the senior person. If you cannot repair it at that time, please pack the vagina, stabilize her, and then take her in theatre. The third cause is because of tissue, that means retained placenta. Usually it should separate within 30 minutes. If it is delayed or if some tissue is retained, it can cause hemorrhage. So the age-old habit of examining every placenta after it comes out is a golden rule. If this is happening, again, catheterize, start the oxytocin infusion. Sometimes intraumbilical vein can be given. Then if you feel that after all this, the placenta is not coming out or patient is bleeding, shift her to the theatre, because manual removal of placenta should ideally be never attempted in the labor. This is something we all, even today, are very, very apprehensive of, DIC. The risk factors would be if she has bled so much, or if she came with an intrauterine fetal demise, you don't even know how long she has been, or she's in a septic shock, severe preeclampsia, or amniotic fluid embolism. Any of these causes can cause DIC. You should suspect DIC if the clotting time is more than 7 minutes, and fresh frozen plasma is the drug of choice. If you don't have it, or even if you have it, transfer her earliest. So basically the key messages for hemorrhage are, if you use active management of labor, always be on alert for PPH. Do not stop oxytocin immediately after delivery, and always use the general principles of ABC. This whatever I've spoken till now is the general basics of obstetric collapse. I wanted to add a few points from Green Top guidelines because this is something which many of us sometimes do not follow. They have issued a very nice warning score chart, which should be used for all women to know that this woman is becoming critically ill. Please remember that if you think this collapse is because of an anaphylaxis, you think, oh, it's a drug reaction, you think it is something like a vasovagal, you think it's something not related to obstetrics, the only way you can check is mast cell tryptase level, which is not available in the labor room. So treat every shock, but this is the only way to confirm the diagnosis. The third thing is that we should know what are the normal physiological changes. So aortocaval compression will significantly reduce the cardiac output right from 20 weeks of gestation. And if the patient is needing the resuscitation, remember that this will reduce the efficacy of chest compression. And that is why a pregnant woman becomes hypoxic much more readily. The ventilation becomes much more difficult, and the changes in lung function, diaphragmatic splinting, and increased oxygen consumption. These are the physiology. Mitra madam, I can see the little one, and it's so beautiful to watch the future gynecologist listening to us.
I do hope at least he becomes a gynecologist, nobody else is there.
So all these factors will make a pregnant woman become more hypoxic. The same guidelines always insist that difficult intubation is a norm in pregnancy, and the pregnant woman is very susceptible to aspiration. We have to remember these two factors. Always tell the patient, manual displacement of uterus to the left. This particular one single effort will help in relieving the aortocaval compression, and this will also help in permitting effective chest compressions. Now, a left lateral tilt from head to toe at an angle of 50 to 30 degrees on a firm surface. This will relieve the aortocaval compression. If there is a major trauma, then the spine has to be protected before you tilt the patient. And so you need a spinal board, or you can manually displace the uterus. And as I said, intubation in a pregnant patient is very difficult. So it should be either done only by an experienced anesthetist. You should not unnecessarily attempt it. These were some points which I found in Green Top guidelines, which I thought are important for obstetric collapse. Although I would advise all of you to read those Green Top guidelines. Very good guidelines. The new ones have come up, and I'll be happy to share them from Royal College. They've just issued recently. So just to summarize obstetric collapse, I would say that trauma in pregnancy, we don't see in our country so often, and especially in the tertiary hospital, because the trauma has occurred because of vehicular accidents on the roadside. But it is a major cause. PPH, of course, we all see, and for that, active management of third stage is the basic for preventive. Preeclampsia and eclampsia, we all have experienced so many times. We need to stabilize the patient, and always, if you are in a periphery, or as Pam was mentioning, if you are in a less equipped hospital, please make a call to your senior obstetrician friend and ask for assistance. So, yeah. I think that basically would cover.
Thank
Thank
you,
you,
ma'am.
ma'am.
Yeah.
Thank
Anju,
you,
go
ma'am.
ahead. Yeah, go ahead.
Thank you, ma'am, for such an excellent talk on this very important, unpredictable, and this very important subject. And you cover this topic in very simple but systematic manner. And I think everybody who has joined this webinar must get benefited by listening you, and especially Green Top Guidelines. Madam, I feel always proud that I am a student, and really I am feeling honored that I am chairing this session. Dr. Monica, thank you very much for involving me. And Bindal Madam, I appreciate always your not only way of working of clinical, but also administrative way of working. Thank you very much, Madam, for giving us such excellent talk.
Thank you.
Madam, thank you. I mean, I was mesmerized. We all were mesmerized. And especially, I would take that, very strong message. The speed at which you talk during a lecture is
Very systematic manner.
very, very, ma'am, very important, because every word enters our system.
Yeah.
We are inhaling every word and it goes and stays.
In our mind, creating picture.
Yes.
Yeah.
Because
One
her
word
talk
for
had
her.
all the cases also, na? And those
Yes.
dialogues which we have heard, which we tell our juniors, अगर perforation नहीं करी तो DNC नहीं करी, collapse नहीं देखा तो obstetrics manage ही नहीं कर रखा. Dr. Bindal, thank you. I know I should have joined later, but I could not resist meeting you, listening to you,
That's
because
very
always you pick
Or-
up some tips. Thank you.
One word for her, she is very, very meticulous.
Yeah. This is the
हमको
most
योग-
important thing.
Very meticulous and in everything, not only this,
Everything, yeah.
everything she takes up, she's to the point, and she I just
वो ना
can't
जो fans होते
thank
हैं
her
ना,
enough. Yes.
Pam fan club करने के लिए ये
Yeah.
basic ingredient है.
Her biggest fan.
Excellence, meticulousness, तो वो हर
And you
चीज
know,
abundance
Mitra,
में.
Thank you, ma'am.
Madam, ज्योति
Thank you,
दीदी
ma'am.
हमको
You have
सिखाते
covered.
हैं one word. ज्योति दीदी हमको राजयोग, योगा जो इतना चल रहा है, they teach us समस्थिति, steady. वो आप तो already, that's what you are. So you are calm and unfettered, undeterred.
स्थिर प्रज्ञ.
She has covered everything what could be we think of in collapse. And I think the team approach must always be there. We foresee the situations and then we
Yes.
have the team with us. Then it becomes really helpful. As I saw in the drill also that the team is there to. In PPH also we
Yes.
have a team. We have a chart. So like this in the collapse, the main cause is PPH. The thing is that, but we should have a team approach. Thank you, ma'am. It was really eye-opening talk and insight into the this dreadful situation where what we doctors come across to. So thank you so much.
This reminds me of a case which I was operating with Veera in her nursing home. Although it was not an obstetric case, Mitra madam, it was a hysterectomy. और उसमें ना एक aberrant branch uterine की कहीं bladder के आसपास थी, जिसको इंजरी हुई थी, and the hematoma 1 second में वो aorta तक पहुंच गया था. I remember एक फिस्ट बना के माइक सीनियर सर्जन ने एओर्टा के ऊपर रख दी, करो अब आराम से मैनेज करो, nothing is happening.
That is very really important. The compression that we use.
Madam Dr. Jyoti, I must tell you, you'll be so happy. मैं अभी लंदन गई थी, जो कॉम्प्लेक्स सिजेरियन सेक्शन का वर्कशॉप अटेंड किया, उसमें internal manual compression of aortic vessel is now a recognized temporizing method. कि जरी प्रोफ्यूज हो तो aorta पे प्रेस कर दो, तो very nice. It will save the patient. इतना इंस्ट्रूमेंट भी निकालने की जरूरत नहीं, प्रेजेंस ऑफ माइंड, बस उठाया और दबा दिया.
और मित्रा मैडम, ये जो as you said फैन क्लब, ये सब बच्चे they've all done worked with me और बहुत डांट खाई है इन लोगों ने. So
मैडम अब हमारे को डांटने वाला कोई नहीं रहा, इसलिए हमें मिस होता है. And God give
हमारा भी मैडम, हमारा भी डांटने वाला भी इंदौर चला गया है. हम लोग भी बहुत मिस कर रहे हैं.
चलिए,
डांटने वाला बस प्लस प्यार करने वाला दोनों.
Madam, write a book about your
Thank you so much, ma'am.
because so many examples you are giving and you have seen it So, right, we would all benefit from that.
Every
Geeta,
HOD guy write a book of memoirs, madam.
Yeah.
Or every word holds weight. And
Yes.
if we can just
Can't
visualize
have enough of
the
them. Yes.
corridors of Kamla Raje Hospital behind you.
Yes.
So thank you so much, madam, for your blessings. It has been a true pleasure and honor to have you, ma'am. इतने आशीर्वाद आज हम इतने किस्मत वाले होंगे मैम, ये कभी नहीं सोचा था.
Oh my God, Monica, thank you so much for giving me this chance.
Thank you so much, ma'am. Thank you. So with permissions of the chair, we move to session number 2, which will be coordinated by Dr. Nandini.
Thank you, Dr. Monica, for involving me. Thank you so much.
Thank you, Anju. Thank you for being there and encouraging us. Thank you.
Thank you, Madam Bindal. Thank you, Monica.
Thank you,
For
ma'am.
involving all of us, this Gwalior OBGY Society, in this wonderful webinar.
Thank you. Thank you to Gwalior. Gwalior is like my home also. So
Yeah, I know.
all my family members only, especially Bindal madam.
Yeah.
Thank you so
We are
much.
one and the same, Gwalior, Indore, Bhopal.
Yes.
Thank you very much.
Good evening to one and all. After a wonderful session on obstetric collapse, we move forward to our second session on resuscitation in pregnancy and perimortem cesarean delivery by a pioneer speaker on the topic of obstetric collapse by Dr. Veenu Kushwaha Madam. The session will be chaired by Dr. Neeraj Yadav Madam, Dr. Amrita Sarkari Jaipuria Madam, and Dr. Kaveri Shaw Madam. Dr. Neeraj Yadav Madam is currently the Secretary of Rewari Obstetric Society. She is a senior gynecologist and director at Yaduvunshi Hospital, Rewari. She has held various posts at Indian Medical Association of Rewari, and she is the president-elect of IMA Rewari. Moving to our next chairperson. Dr. Vishal. Dr. Vishal, CV of next
I have changed the
chairperson.
slide.
No, it's not changing. We are
Yes, I
still
have
on.
changed the slide.
There must be some network issue, Vishal. Yeah, now
Just
it is.
a minute.
Now it is changing.
Okay. Thank you. Moving to our next chairperson, Dr. Amrita Sarkari Jaipuria Madam. Madam is consultant at the Jaipuria Medical and Research Center and Garg Hospital, Gorakhpur, UP. She is currently the Vice President of Gorakhpur Menopausal Society. Madam has held various posts at Gorakhpur Obstetric Society. She has been the organizing secretary of various
It's okay,
national
Dr. Nandini. It's okay. Thank you so much. Thanks for the opportunity.
Thank you, ma'am.
Okay.
It's an honor to introduce you. We welcome you, ma'am. Moving to our next chairperson. Dr. Kaveri Shaw Madam. Madam is currently the director at Vijay Women Clinic and Golden Women's Clinic. She is currently at the secretary of IMA. The secretary of IMA Women's Doctor Wing, Jabalpur. She is the national trainer for Manyata Project. She has presented. Which was presented at CEPHOC conference. She is also the editor of Mimamsa monthly bulletin jogs. She has the credit of first robotic surgery of Madhya Pradesh. She is also the editor of High Risk Pregnancy Beyond Obstetric ICOG campus book, and she has various prestigious awards to her credit as the Best Saheli Symposium Organizer National 2024, Foxy Outstanding Contribution Award, Safe Motherhood Committee Foxy Appreciation Award, and the list goes on. Ma'am, we welcome you as a chairperson.
Thank you so much, Dr. Nandini.
Thank you, ma'am. Now I request our chairpersons to kindly introduce the speaker for today.
Thank you, Dr. Nandini and Dr. Monica, for giving me the opportunity to chair the session, because I've heard Dr. Veenu Kushwaha many times, quite a few times, and it is always a treat and a feast to hear her. And as we can see from her CV, that she has been awarded right from her childhood days, or I must say as an MBBS student. Also, she has been awarded for her publications. She has received the West Zone Kamini Rao Orator Award, the Foxy Corion Award in senior category. Then also appreciated for her training So she has been awarded as a trainer too, and outstanding faculty also, and has been a great researcher. So everywhere she has been awarded.
Thank you,
And
ma'am.
her-
Thank you. Good evening, ma'am.
Good
Ma'am,
evening.
my teachers
And
are
on-
sitting here. So
but-
please,
And they must be proud of you, Dr. Binu. It's a matter of great pride. As a chair, I'm feeling so privileged. So your teachers must be really proud of you. So you've held
somehow
many
my
positions.
video has stuck, ma'am. Give me a second. It's not starting. I don't
Okay,
know why
okay.
this all happens when there is a webinar going on.
It doesn't happen.
Okay.
It's a good omen, Binu. It's a good omen.
Okay,
I
okay.
don't know, ma'am.
So
That goal is just,
so many publications to your credit, and you have held so many positions. Your organizational capabilities have been acknowledged. So
Thank
over
you,
to
ma'am.
you,
Thank
Dr.
you so
Binu.
much. Maybe I may have to join again because this is just not responding. Dr. Monica, may I join again? Leave and join again if you say?
Yeah, definitely.
Yeah,
Yeah.
And
please.
I
give me a
want
minute.
to also add while you are trying to do all this, हम जरा stage संभाल के रखते हैं क्यों Dr. Amrita?
Yes, ma'am.
Binu is such a wonderful organizer. I had the privilege to participate in her workshop and the conference of MPOGs, and I got an opportunity to meet all the wonderful Madhya Pradesh wale dynamites. और ये Dr. Shashibala और Dr. Veera absent थे. They were conspicuous by their absence, but I'm glad that I'm meeting you digitally. So Binu had arranged a critical care workshop in her medical college, which was phenomenal. And of course, the conference also of 2 days. मैंने 3 दिन जाके रेवा में बहुत मजे मारे. So Binu, I hope you can start your presentation. And
Bino has brought Riva on the watch list,
Yeah.
top list, you can say. She also has her roots, I think, in Gwalior.
Yes, ma'am. Yes, ma'am. She has done her
Yes,
GRMC, her PG from
yes,
Our Lady Harding.
I know. So something GRMC का तो कमाल है ही.
मैंने कहा मैम GRMC का सबका होता है connection.
नहीं.
I don't know.
swear.
मैम कहीं ना कहीं से
I
मिलता
think she is from Gwalior only. She is a
Yes.
Gwalior girl only, I think.
So
As
thanks.
much she has worked in, I was in Riva, and she's fabulous in her academics. We really enjoy the discussion part in academics whenever there is some
Madam, yeah,
case.
madam, आप कहिए. Looking forward to coming to Gwalior.
Thank you so much, Amrita ma'am, for your lovely introduction and
My pleasure, my pleasure.
for being there. Such a senior person amongst us. We are honored, madam.
Even I'm honored to see all the dignitaries here, Dr. Mitra Saxena. I heard Dr. Jyoti Bindal talking, so it was great. Madam Pam.
So, Amrita ma'am, could you tell us a little about your surnames, which are very intriguing?
Jaipuriyar.
Yes.
Jaipuriyar. Why?
Acha,
we belong to my husband's side. They belong to Bihar only, and there's a probably village in Bihar from where they belong, and so from there comes the title of Jaipuriyar. So it has nothing to do with Jaipur. So Dr. Maninder Ahuja always forgets. Oh, Amrita, tu Jaipur se? I nahi, Gorakhpur se.
Yeah, because I also meant to ask, but now since we have time, I thought it's better I can ask like this. Because in conferences, we don't get time to chat, ma'am.
Yeah.
We are always rushing around.
So, Sabine, I mean, she's still not here.
I think she has not joined.
Binu can talk extempore.
नहीं, madam.
She can talk extempore.
For the
Madam,
listeners, for the benefit of listeners. Yes.
Good evening, everyone.
Hi, Juhi. Please, can you talk something about something?
Yeah, I am acting as a filler.
Please.
Binu,
Ma'am,
presentation
can we
भेज देना?
start our video?
She
Can
can
we
send
share
her
that
presentation to Monica.
What
Yes.
which video has it been? Acha, that video which
The drill.
sent, the drill.
Can we ask the organizing team? I mean the manager people, Vishal and all.
Mitra ma'am, can we share the video?
Yes,
what-
Mitra's video. I
Yeah,
want
she
to
has
see.
joined.
She has joined.
Okay, joined.
Yeah.
Good.
Yeah, Dr.
Good
Tino,
evening, ma'am. But my PPT is not here on phone, so I have WhatsApp that in group. So if someone can just a sec, I think this thing has also started. Just a second, ma'am.
Don't worry.
Yeah.
सारे important people के साथ ऐसे हो रही
कुछ नहीं होता, ये सारे important people तुम्हारी family के हैं, हमको कोई वो नहीं है.
But this is better than obstetric collapse.
Should I share the PPT?
Yeah.
No, now it's working. I think I'll be able to share now.
Okay.
So good evening, everyone. I hope Jyoti Bindal madam is there. Has she left already? I really wanted to be speaking in her presence.
Madam is there. Madam is
No, I'm very much here. I dare not leave, Vinu.
Good evening, ma'am. Good evening. I mean,
very
for
keen to
me,
hear you.
ma'am, the most important, aspect of this particular webinar for me is that I'm speaking in presence of you. So thank you so much, ma'am. Thank you so much, Dr. Monica, for giving me this opportunity. Although maximum of my part has been covered by madam already as a teacher, she once again has helped me. So I would now try to only cover the PMCS, right? So is it being seen?
Yes, we can see. You can put it on slideshow now.
Yes.
Yes.
Yeah. Is it
Yeah,
fine now?
we can see now.
Yeah.
That's good.
Thank you. So good evening once again. My topic for today's webinar is resuscitation in pregnancy and perimortem cesarean section. So what is perimortem cesarean section? Because it is a perimortem cesarean section which I would be focusing upon most as a part of resuscitation during pregnancy. That because this is the only thing which is different from another person who is non-pregnant, whose resuscitation is being performed. So in a pregnant lady, it is the perimortem cesarean section which makes a difference. So a perimortem cesarean section is defined as a C-section performed during imminent cardiac arrest or active cardiac arrest, that is maternal collapse, with an ultimate goal to successfully resuscitate the mother and improve fetal survival. So since our older times, we have been, although listening this term perimortem cesarean section, but it was mostly for the procedure that was being done on a dying mother or a dead mother, where we used to take out the fetus just for the ethical reasons, right? But here this perimortem cesarean section is being used in a different scenario, and it is actually also called as resuscitative hysterectomy. So actually it is a part of the resuscitation process that we do in a case of maternal collapse. It is not that age-old perimortem cesarean section which we all have been mostly reading about. So nowadays, this perimortem cesarean section is more preferably called as resuscitative hysterectomy because it is being done as a part of CPR of a pregnant lady. So otherwise it may be called as PMCS. So role of perimortem cesarean section or resuscitative hysterectomy after a failed CPR has been established since 1980s, but somehow in India it is still not a well established practice. So what exactly is maternal collapse? Madam has already defined it. So it is an acute event involving cardiopulmonary system and or brain resulting in reduced or absent conscious level at any stage in pregnancy and up to 6 weeks after birth as per RCOG. As it can have devastating consequences and even death, initiation of timely resuscitation is very important here. So time is very important. How quickly you perform it, that is very important. So these are the causes of maternal collapse. These also have been discussed by madam. Mostly we remember them by mnemonic BUCHOPS and 4 Ts. So reasons are those only: hypovolemia, hypoxia, electrolyte imbalance, hyperkalemia, hypothermia, toxins presence, tension, pneumothorax, tamponade, thrombosis, so these are the reasons. And if we talk about the pregnancy, it is mostly those causes like hemorrhage, eclampsia, and sepsis. Hemorrhage may be antepartum or postpartum, but here we are basically talking about a pregnant lady who is carrying a baby. So early identification is very important, that the cardiac arrest, are there any risk factors which make a lady prone to go into cardiac arrest? There would be high risk mothers who are being monitored through various risk factor identifying criteria like MEOS, GCS, SOFA, quick SOFA, or AVPU. But I tell you, majority of the cardiac arrest, that is obstetric collapse, happens in unsuspected cases. So the preparation is very important here. Like we say that in PPH, in 60 to 70% cases, the cause is not identifiable. So we have to be prepared for each and every case. So here also we have to be prepared for each and every pregnant lady, because there is a possibility that she may go into cardiac arrest or obstetric collapse. So timely resuscitation and management, the main components are general and related with the obstetric scenario. So ABCDE approach that we use in a general patients, non-pregnant patient, CPR also, that would apply here as well. BLS protocol, basic life support, the components of CPR would remain same, but here we call it activate code blue. Code blue is there for non-pregnant also. For any person who has collapsed, the code blue gets activated. So we have to activate that. Call for help is very important, because you need multiple people to do multiple tasks. Early decision for intubation is very important here, as described by madam about the physiology of a pregnant lady. She may go into this hypoxia very quickly. And this intubation is difficult also here. So early intubation and by a experienced person, both are very important. Then lateral displacement of uterus. So we all know that the uterus compresses the inferior vena cava. So that reduces the blood flow to the heart. So if we displace this uterus, the cardiac output would be increased. So that would help in regaining the blood pressure. So these are the general measures which we take care of. Then the obstetrics or specific measures are control of hemorrhage or the cause, whatever is the cause. And fluid management is very important. Through the large bore cannulas, fluid should go fast. Removal of the septic foci, correction of the drug toxicity. In our cases, it is mostly the magnesium sulfate toxicity, but there may be other drugs also. So you have to identify that also, and this all should go simultaneously. So you would be like managing the patient and trying to find out the cause and managing that specific cause. Both things you will be doing simultaneously, and the things will be performed by multiple people. It is a multidisciplinary team approach which is going to work here. Nowadays, role of 2D echocardiography is coming up in a very big way. They say if you find like breathlessness or any chest or cardiac symptoms in a pregnant lady, you should always make her undergo a 2D echocardiography, because peripartum cardiomyopathy is not that uncommon as we used to think it earlier. It is pretty common. So only thing that we never used to do the echocardiographies earlier, but now with the availability of this facility more, we should be doing in all cases, all pregnant patients who have chest or cardiac symptoms. Then comes the role of PMCS, perimortem cesarean section, or resuscitative hysterotomy. So this is one thing which is peculiar a pregnant lady. If you take out the baby, that increases the survival of a lady up to 60 to 80%. Why? Now, this part has also been covered by madam. So pregnant women are more prone to become hypoxic rapidly in comparison with the non-pregnant women. Then an enlarged gravid uterus beyond 20 to 24 weeks of pregnancy results in considerably reduced venous return due to aortocaval compression. In addition, enlarged gravid uterus interferes in performing efficient chest compression. a pregnant lady requires more quick chest compression. They say this compression part, chest compression, comes first in management of a obstetric collapse lady. Like in a non-pregnant person, it is ABC, but here it starts with C. So chest compression is the first thing that we should be doing because a lady may go into hypoxia very quickly. So with that presence of enlarged uterus, you would not be able to perform those chest compressions efficiently. So that is why also we need to remove the fetus to, reduce that bulk from the abdomen. Then PMCS helps in relieving both of these factors, like it is increasing the cardiac output also, and then it helps in improving the efficiency of chest compressions that we are offering during a CPR. So evidence-based benefits, if we talk about, every literature says that delivery of the near-term fetus provides up to 60% improvement in cardiac output, and which further results in improved maternal survival rates by 30 to 70%. And neonatal survival is improved by 98% if delivered within 5 minutes of maternal cardiac arrest. Although our primary objective is not here to save the baby, the objective is to save the mother. But it has been seen that the benefit to the baby is even greater, but if should have been done within 5 minutes of the event, that is cardiac arrest. So when should we be performing it? As I said, within 5 minutes. Earlier, the rule was 4 minutes. That if at 4 minutes of cardiac arrest with your CPR, the lady has not regained the consciousness, you're supposed to perform the cesarean delivery at 5 minutes. So last year only this limit has been increased to 1 minute. So if with maternal CPR, consciousness is not regained for 5 minutes, infant delivery should be taken by 6th minute. Maybe it is easier to remember, or maybe they wanted to give 1 more minute by performing some drills and they found out that this is the more convenient time period without affecting the efficiency of it. But many of the literature says that even after 5 minutes also you can perform it, because benefits have been seen if it is performed even till 30 minutes post arrest. So there is no harm in performing it even if you perform it later. But the maximum of the benefit is gained only if you perform it after 5 minutes of the event. So what are the current guidelines? All current guidelines recommend performing PMCS at the earliest to empty the uterus if a mother doesn't respond to BLS and ACLS. All, like ACOG, RCOG, American Heart Association, they all endorse it. But I somehow feel that FOXI categorically has not come up with a statement of including PMCS or resuscitative hysterectomy. Preferably it should be called, because PMCS is somehow a derogatory term. It looks like it sounds as a negative term. So I would say resuscitative hysterectomy is a better term to be used, and it should more be promoted, and its role more should be highlighted in management of a case of obstetric collapse. So this is the algorithm of management of maternal collapse. Whenever you see a lady of obstetric in obstetric collapse, you continue with your BLS and ACLS protocol. That is, you deliver a high quality CPR. Defibrillation and role of intubation is very important in a pregnant lady. In other cases, we use them slightly later, but here they should be used at earliest. Their role is very important here. Early intubation and use of defibrillation. Then other ACLS interventions in the form of giving epinephrine or correcting the dyselectrolemia or giving amiodarone, they should all be going on simultaneously while we are taking decision for performing this PMCS, right? So along with that, you should always try to find out the etiology, because unless you correct the etiology, you are not going to manage the patient effectively. So perform maternal interventions in the form of perform airway management, administer 100% oxygen, avoid excess ventilation, obviously, place IV lines always above diaphragm If receiving IV magnesium sulfate, then stop and give its antidote and then continue BLS and ACLS. Then what about the obstetric interventions? Providing continuous lateral uterine displacement, detached fetal monitors. We are not worried about the fetus here, please. It interferes with the steps of CPR. So please detach all the fetal monitors and prepare for perimortem cesarean delivery timely. That is very important. It should be in our minds that okay, that is also like we automatically start doing those chest compressions, we automatically start infusing fluids. So this also should be going on in our mind, that when to take the patient for PMCD. So timely decision is very important here, and perform a perimortem cesarean delivery if no regain of spontaneous consciousness is achieved in 5 minutes. And then hand over the baby to the neonatologist. This is the lateral displacement of the uterus, how we do it. So it can be done with one hand technique or two hands technique. So they both are more or less equally effective, but the thing is, use of pillow or tilting of the bed should not be used here, because they are not that much effective. One thing, other thing, they hinder in our this chest compression, performance of chest compressions. So it should only be the hand which should be used for purpose of displacement of uterus. So where to use the one hand or a double hand technique? So when you are performing, you are doing the CPR only, then the double hand technique actually is more effective and convenient also for the person who is doing it. So that should be used. But if PMCS is also being performed along with CPR, then you need more space. And then because two-hand technique covers the abdomen, so to expose the abdomen, here you will have to use one-hand technique. So this only is the difference, that you should know when to use two-hand and when to switch to one-hand technique, but it should be going on continuously. That is important. Then how to proceed for PMCD or PMCS? So resuscitation efforts must not be altered. That is the most important part. Your CPR should be going on. Steps of CPR should be followed religiously. This PMCD decision should not affect your CPR efforts. To accommodate the cesarean section procedure, since maternal recovery is still possible. हो सकता है कि आपने बस PMCS के लिए आप इंसिजन देने ही वाले थे और उसके जस्ट पहले she has regained her consciousness. So that CPR should be going on simultaneously. And also rapid delivery is crucial for both mother and fetus. Hence perimortem cesarean section optimally should be performed at the site of the arrest. Nothing like कि आपको उसको OT ले जाना, you have to prepare the area, you have to take the patient to OT, you need to catheterize the patient, you need to take the consent, nothing. Without all this, it has to be performed on the site. Recently, I think last year only, a lady who was waiting in a queue in Apollo Hospital, Delhi, maybe full-term twins or something, she went into obstetrics collapse. She just fell down in that waiting area, and there were no facilities available for this perimortem cesarean section, and court gave the decision that it was wrong and the hospital was fined. So this facility for this perimortem cesarean section should be available at every place where a pregnant lady is being handled. So patient transport during chest compression results in decreased compression effectiveness and additionally delays the surgery. राइट अगर आप ट्रांसपोर्ट कर रहे होंगे तो आप CPR चेस्ट कंप्रेशन उतने अच्छे से नहीं दे सकते, एंड ऑल्सो दैट जो टाइम लिमिट है मैक्सिमम बेनिफिट की, दैट ऑल्सो विल बी क्रॉस्ड. So it has to be done at the site where actually the arrest has happened, the ward, the ICU, wherever, your OPD, it has to be done then and there because it is a part of CPR. So what is the procedure? Use any of skin incisions, vertical or transverse, but they say vertical is more quick, but whatever you are good at, you can give the incision, but Preferably, if the lady is less than 28 weeks, then it is better to give a vertical uterine incision. Uterine massage and catheterization would be performed later on. Neonatal resuscitation to be started immediately by other person. Maternal resuscitation, all the components of CPR should be going on simultaneously. And we should not be doing the closure on site. If she has regained the consciousness, we take the patient to the OT and do the closure in OT later under aseptic conditions. Then what are the equipments? If I talk about the basic PMCS tray, it is only a scalpel and 2 hemostat arteries or cord clamps which are required to perform a perimortem cesarean section. So keep this tray ready everywhere where a pregnant lady is being handled in a hospital or healthcare facility, wherever, right? And the people attending the pregnant females should be knowing where this perimortem cesarean section tray is lying in that particular ward. And after that, once you have done the things, you would be asking for other things from your sister, which she can meanwhile bring from your OT or the LRs. So special precautions to be taken, routine preparations like such as placement of a urinary drainage catheter or surgical preparation, just do not do it, please, because it is time consuming and therefore irrelevant. Time is the most important thing here. So since tissue perfusion during arrest is suboptimal at best, so once you take out the baby, the circulation has improved now. So return of spontaneous circulation may be associated with reappearance of bleeding. So bleeding is a rule here after you take out the baby. So uterotonics should be used to limit uterine bleeding, and prophylactic misoprostol should be given in the form of 800 microgram per rectal misoprostol, because oxytocin may cause hypotension further. So no oxytocin here, only the prophylactic misoprostol per rectal, because atonic PPH is almost a rule. After the procedure, there would be 2 situations. Either the consciousness would be regained or it would not be. If the lady has regained the consciousness or circulation, then patient to be taken to the operation theatre. Proper wound closure is to be done. Appropriate antibiotics to be started, and aftercare treatment is given in intensive care unit. And emotional support to the patient and the family is very important after the procedure. So always involve a psychiatrist also here. Then if the consciousness or the spontaneous circulation is not achieved, then at the time of declaration, all IV lines and intubation instruments should be left in situ, so that the relatives or the attendants see that what all measures you have taken to save our lives. So let those IV lines and intubation instruments be in place while declaring the death. Then uterus should be left unsutured, while skin may be aesthetically sutured. Everything to be recorded meticulously and relevant authority to be informed. This all thing is very important nowadays, we all know. And then the debriefing of staff. We all should be speaking same language after the event has happened and we have managed it, whether she has gained the circulation or not. So debriefing of staff at the end of the procedure is very important. Each and every member of the team should know what has happened, what is to be said. So it should be come in a sequential manner and it should be same for all. So what is the role of debriefing after the event? First you debrief your staff or the team members. Later on you debrief the relatives also, right? With detailed exploration and discussion of the events. These are often held separately, obviously, first the staff and then the relatives. And later on, once you understand that, okay, you have properly explained them, later on a joint meeting may be requested if especially the attendant wanted. The debrief can involve members of the multidisciplinary team, including paramedics, very important. Your technician may speak something else outside. So paramedics and staff from accident and emergency theatre, emergency OT, critical care and maternity departments. And this must be undertaken at an appropriate time in a suitable place. ऐसा नहीं है कि एकदम से सब कुछ हुआ और तुरंत आप उनको बोला ये करना नहीं. Take your time. First you complete the notes, then you yourself decide what to be the sequence of events that is to be narrated to the team. So you take your time, and then at an appropriate time, after you understand that, okay, this is the situation, then at the suitable place, not in OT, not in ICU, just go in the room beside the OT, you all sit down there and debrief the staff. What are the legal considerations? So law allows us, madam is sitting here, who would be a better person to further say a few words on it. So law allows us to perform any surgery to save a dying patient's life. Till date, no litigations for performing a PMCS have happened. On the contrary, 2 lawsuits have been filed in the USA and 1 in Europe for not performing a perimortem cesarean section, and that happened in India also last year actually. So choice is yours. You want to get, sued, or you want to, means you are saving yourself also, and obviously you are saving a mother. That is the main objective here. Consents and documentation. All steps of the whole event and procedure should be noted down in patient's file as instructed by team leader. Despite being an invasive procedure in the emergency setting, perimortem cesarean section should not be delayed in an attempt to obtain consent. ये आप बार बार बोल रहे हैं कि हमको कंसेंट नहीं लेना है. इसकी मतलब बाद में हम एक्सप्लेन करेंगे, बट बिफोर स्टार्टिंग द प्रोसीजर वी आर नॉट सपोज्ड टू टेक द कंसेंट फॉर द procedure per se. Your colleague will be explaining the situation to the relatives, yes, but once you have to perform that cesarean section, you do not need to take the consent for that particular procedure. So the doctrine of necessity allows physicians to provide this treatment if it represents the best interest of the mother and child. After the procedure, team leader should explain relatives all steps in a manner that is understood to him or her, and if possible, recording also to be done that you have explained it all, right? So what are the do's and don'ts? So indications for a cesarean section: if there is no return of spontaneous circulation after 5 minutes of cardiac arrest, despite good BLS and ACLS and correction of reversible causes. Unsuccessful chest compressions, obvious non-survivable mother injury with viable fetus. तो ये कई बारी ये सिचुएशन भी होती है, ये कोविड में भी हुआ है, that there is an obvious non-survivable mother but the fetus is viable, so then there also this 5 minutes time may have crossed, but we'll have to take out the baby. So here also you are supposed to perform a perimortem cesarean section. What are the contraindication? If the gestational age is less than 20 weeks, because uterus is not that much enlarged here that you need to take out the baby to do the resuscitation, except in cases of multiple pregnancies where uterine height may be more, even if she's 20 weeks or less, then return of spontaneous circulation after brief period of resuscitation. She may regain her consciousness before 5 minutes. So, and in that case also you are not going to perform perimortem cesarean section. So before 5 minutes of ongoing CPR, that is also important. ऐसा नहीं है कि चली गई CPR में चलो chest compression and perform the PMCD straight away. No. So it is to be, you have to do those CPR steps for 5 minutes, but yes, keep in your mind that PMCD is also a step of CPR in a pregnant lady. So that is very important. So I would just quickly go through the real life case scenario. A chronic hypertensive with superimposed preeclampsia at 37 weeks presented to me with pain in abdomen. It was COVID time in 2021. She suddenly developed breathlessness with creps all over. She was treated with injection Lasix and loading dose of Maxelf as her BP was very high and she was still not able to maintain saturation. She was shifted to ICU quickly. But in ICU, as soon as she was shifted to the bed, she went into cardiac arrest. CPR was started immediately with BLS and ACLS protocol, but she didn't respond. And PMCS was performed in ICU bed itself. Mother and baby both survived. Later on, during postpartum period, she was diagnosed as dilated cardiomyopathy by cardiologist with ejection fraction less than 15%. So here comes the role of echocardiography. Maybe if it was done during antenatal period, we would have been in a better situation to manage her. Maybe we would have taken her for cesarean section straight away. But that was COVID time. She directly from 24 weeks came to us in 37th week. So that is why we could not perform this echocardiography for her. So, as per my knowledge, this is country's first case of its kind because it was done out of OT in ICU bed. It was done as a part of CPR. So it was initiated within 5 minutes of cardiac arrest, and CPR continued throughout. The compressions were actually going on when I was performing these cesarean sections. Mother and baby both survived, and on 4 years follow-up, both are doing well. So one timely decision taken, I don't know how did I take that decision. I really don't know. Maybe in some previous conferences or in webinars, I was listening to this thing made a space, made a very strong impact on my brain somewhere that, okay, this is a part of CPR. So it suddenly came in my mind and I just did it. So that is what. So one timely decision taken and 2 beautiful lives saved. So this is the summary. Maternal collapse, whenever it happens, you start with the cardiopulmonary resuscitation. You continue it with now the 5 minutes duration. If the spontaneous circulation has returned back, you stabilize the patient and transfer her to ICU. But if it has not and the gestational age is more than or equal to 24 weeks or even lesser gestational age, with the fundal height reaching up to umbilicus, then you are supposed to perform perimortem cesarean section. If the return of consciousness has happened now, then you take the patient to the OT and do the suturing under aseptic condition, and then you give uterotonics later on also with the antibiotic prophylaxis. But if the regain of consciousness has not taken place, then also aesthetic wound closure has to be done. So this is the summary of the entire event. So these are the take-home messages. PMCS C-section kit. PMCS kit is to be kept at every place where maternal collapse is a possibility. And it is a possibility wherever a pregnant lady is being handled. So keep it in every ward, I would say, but especially in emergency ward, ICU, LR. These are the places जहाँ पे कुछ sick patients ही आएंगी आपकी, तो वहाँ पे होना ही चाहिए. And then, but actually guideline says everywhere where the maternal collapse is a possibility. Continued staff education is very, very important. Drills and telling them about the PMCS protocol. Every health facility should, where this deliveries are taking place or full-term pregnant ladies or pregnant ladies are being handled, there should be a written PMCS protocol. It should be there on their SOP. And the quicker the PMCS is performed, the better the maternal and neonatal outcomes. And that would only happen if we keep on doing it through drills. So timely decision, this is the most important, these 2 words are the most important one from today's this PPT. So timely decision is very important, and obviously the role of multidisciplinary teamwork is of great importance here, because not only when you are doing this all, later on also, this whole event leaves a big impact on a lady's a mental status, and you also are in so much stress that how to deal with the things which later on take place. So have a team, and as I said, I would again like to say that please start using, please start taking advantage of this echocardiography in pregnant ladies whenever you see even minor symptoms, chest or cardiac symptoms. So thank you so much. Thank you so much, everyone. I'm really, really feeling privileged speaking before you all. Mitra madam, obviously Jyotivinder madam. Thank you so much. Thank you so much.
Thank you, Dr. Binu. That was a beautiful talk. Your chairpersons are there. Amrita ma'am is there. Amrita ma'am, would you like to say a word?
It
Yes.
was a wonderful talk, Dr. Binu, and you covered everything. So, and I also saw the lady which was recovered and with her child. So it was wonderful listening to you as always. And
थैंक
over
यू
to
मैम,
other
थैंक यू मैम,
chairperson.
आपको इतने दिनों बाद देख के बहुत अच्छा लगा.
Binu, you are the trailblazer of MP. You do things differently. Not only are you very beautiful, but
Yes.
your thoughts are also very beautiful and very clear. And you know what you want, and you know what to teach, and you get your point across. And
Thank you, ma'am.
you have the courage to do things differently, I feel.
Monica,
Thanks
beautiful
for
mind,
those
beautiful
words,
body.
Thank you,
So,
ma'am. Thank you.
so I'm you have given a very good culmination to respected Bindal madam's talk. Madam walked us through the labor room, and you ultimately gave us the perimortem C-section, mother and baby back. So, I mean, it's really incredible. And I'm so happy you could be a part of our program. And I wish that you participate again and again, not as faculty, but
Definitely, ma'am.
as
In
faculty.
any form, in any form. Thank you,
I
ma'am.
wish
Thank
you
you.
all the best for your FIGO participation.
Thank you so much, ma'am.
you.
Thank you so much.
It was a wonderful talk. I just want to know one thing you have mentioned, like among contraindications.
तुम
that
अपनी
in
बेटी को भी दिखा रही हो ये PMCS?
दोनों बैठ के पढ़ रहे हैं, मम्मा क्या पढ़ रही है. मैंने बोला मैं क्लास में हूँ, मैं घर नहीं आऊंगी, तो दोनों यहाँ बैठ के देख रहे हैं मम्मा क्या पढ़ रही है.
My God. बताओ बताओ.
So you were saying like in case of multiple, then what should be done in case of multiple pregnancy? Just I want that point. You're
नहीं,
saying
I only said the point was at PMCS generally is indicated when the uterine height is more than 20 to 24 weeks, because then only it is going to interfere with the blood flow to heart, blood flow, and then only it is going to interfere with your chest compressions. अगर यूट्रस उतना बड़ा है ही नहीं तो फिर PMCS करने का कोई सेंस नहीं है. लेकिन मल्टीपल प्रेगनेंसी में इवन इफ शी इज 20 weeks, then also her uterus may be enlarged up to 24 weeks or beyond. So in those cases, it is not the gestational age, it is the clinical examination, the fundal height of the uterus that is important.
So, Dr.
Right.
Binu,
It was
this has got
wonderful talk. Thank you.
Thank you.
Thank you, Kaveri, for your expert comments. And Binu, this has got nothing to do with the fetal viability, no?
Ji, ma'am. No, ma'am.
No, not at all.
It is only being done for the mother.
Yes.
You get the baby as a bonus.
Yeah.
क्योंकि आप जल्दी करोगे तो बच्चा मिलेगा ही. बच्चे का सर्वाइवल रेट और भी ज्यादा है with PMCD, timely PMCD.
Yes, because this is the first time I'm listening to a lecture of PMCS. What I noticed with Bindal ma'am's lecture and your lecture, you're just talking about fundal height. You have not mentioned the gestational age at all. So it is totally irrelevant what the gestational age is, as long as you can relieve the compression of the abdominal aorta.
Yes. It is the essential step of CPR in a pregnant lady.
Yes.
That is the thing.
Yeah.
That is the new
हमारे time पे
guidelines.
PMCS माने
And
कोई
no more,
pregnant
Monica,
Yes,
they are
ma'am.
not supposed to write PMCS. No
Yes.
more we should write perimortem cesarean section. We have to write the word resuscitative hysterotomy. So whether you do it to take out alive babies or to resuscitate, after 24 weeks of height of uterus, resuscitative hysterotomy is a part of the cycle of CPR, like Binu has very clearly mentioned. We will highlight it again.
Yes, ma'am. I really want to this term to be changed to resuscitative hysterotomy.
No more it is going to be written in our documentation also.
Yes,
but I must congratulate you, Binu. You're an excellent teacher. Very beautiful.
Ma'am, I just try. आपके सामने तो we are nobody.
मित्रा मैम, आपने इसकी कविताएं नहीं सुनी है.
अभी सुनेंगे यार, तुम मध्य प्रदेश वाले क्या हो?
मैम ये ना बोलती है कविताएं हिंदी इंग्लिश पता नहीं क्या क्या बोलती है, and we just keep listening कि how she whether she's a gynecologist or
दिल एक ही है, बार बार नहीं ले सकते. जी वो रेवा जाके दे आई थी.
She's a very big bundle of energy, you know.
All of you, yeah.
No, ma'am. We learn from all of you. Yes.
Okay, thank you.
So just
much
give
for
us the screen share.
Yeah, ma'am.
Thank you, ma'am.
Because we are ready. Armed with our...
आपके लिए मैम थोड़े से कुछ शब्द बोल दें before starting.
हाँ वो कर लो जो
Yes, ma'am.
करना है।
हाँ चलो आ जाओ श्वेता स्टार्ट करो बेटा। हाँ।
ओ सॉरी मैं तो पागल हूँ। कहाँ गया तुम्हारा? उसके नीचे लास्ट में चाहिए तो अभी नहीं आएगा।
Shweta, you are muted.
Muted. Still muted.
बहुत लंबा टाइम बहुत जल्दी
No, can't hear you, Shweta.
So, moving to our panel discussion, that is on obstetric collapse, real life scenarios, and multidisciplinary management. We welcome Dr. Mitra Saxena ma'am for moderating the panel, and Dr. Padma ma'am with a co-moderator with her. And we have experts Dr. Beenu Kushwaha ma'am and Dr. Juhi Agarwal ma'am. Dr. Mitra Saxena ma'am, madam is present, is immediate
आगे चलो
chairperson, practical. Ma'am, थोड़ा practical.
बस दो लाइनें बोल दो।
obstetric
past
gynecology.
chairperson for practical obstetrics and now running for vice president election.
And now ma'am is running for vice president elections. We welcome you, ma'am.
Thank you.
I would just
Next
like
we
to
have-
introduce Dr. Mitra Saxena with your permission, Purva. Mitra ma'am
Yes,
is
ma'am.
the driving force for this webinar. She has beautifully steered the Practical Obstetrics Committee of FOXY through 2 years. The first time I understood internal iliac ligation was
Yes,
because
yes.
of her videos. And she has also stepped into the arena of the vice president election with a very novel concept of Teachers Tuesdays and Tuesdays with Teachers, which is taking everybody by storm by the sheer novelty with which it is executed. So, Mitra ma'am, thank you so much for your efforts, and we wish you all the best in whatever you dream of.
Thank you. Thank you.
Next, we have Dr. Padma Yadav ma'am. Madam is presently consultant obstetric and gynecologist at Kalmaje Hospital, Rewari. Madam is presently treasurer of Rewari Obs-Gynae Society and has a special interest in gynec laparoscopic surgeries. We welcome you, ma'am.
Thank you so much.
Next, we have our expert, Dr. Beenu Kushwaha ma'am. Madam is presently professor in
Please,
Department of
Purva, please leave it.
Bas, ma'am, that's it.
Thank you.
SSMC Medical College. Next, we have Dr. Juhi Agarwal, ma'am. Madam is professor and unit head in Department of Obstetric and Gynecology, Gandhi Medical College,
Thank
Bhopal.
you. Go
And
ahead.
unit in charge. Madam is having to her credit various publications and is very active in Bhopal Obs-Gynae Society. We welcome you, ma'am. Next, we move on to our enthusiastic and dynamic panelist. We have first with us Dr. Amrita Jaswani, ma'am. Madam is presently consultant Jaswani Hospital, Gwalior. We welcome you, ma'am. Next, we have
Next panelist is Dr. Anubhuti Mohan Singla, madam. Presently, she is working as a consultant obstetrician at Sachdeva Hospital, Rewari, and she's the secretary of Rewari Obs-Gynae Society. We welcome you, ma'am.
Next, we have Dr. Charu Mittal, ma'am, from Gwalior. And ma'am is ex-professor from Baroda, Gujarat. And madam has a vast experience, more than a decade. We welcome you, madam.
Next, we have Dr. Divya Yadav, madam. Madam is associate professor, SN Medical College, Agra. We welcome you, ma'am.
Next, we have Dr. Kiran Yadav, madam. Madam is currently consultant at Pushpanjali Hospital, Rewari, with a special interest in gynec laparoscopy. We welcome you, ma'am.
Next, we have Dr. Monica Jain, ma'am. Madam is chairperson, IME Women's Doctors Wing, founder, treasurer, Gwalior Menopause Society, and executive member of GOGS. We welcome you, madam.
Next, we have Dr. Nidhi Bansal, madam. Madam is presently secretary of Agra Obs-Gynae Society, and we welcome you, ma'am.
Next, we have Dr. Raj Kishori Dandodia, Madam. Madam is an assistant professor at GRMC Gwalior. She is a past executive member of COGS. We welcome you, ma'am.
Next, we have Dr. Rashmi Agarwal, Madam. Madam is Consultant Director of Mangar Nursing Home and Research Center, Gwalior, and a very active member of Gwalior Ops and Gynae Society. We welcome you, Madam.
Next, we have Dr. Renu Jain, ma'am. Madam is presently Associate Professor at GRMC Gwalior. We welcome you, ma'am.
Next, we have Dr. Shweta Yadav, Madam. Madam is Joint Secretary of Rewari Ops Gynae Society with a special interest in high-risk pregnancy and infertility. We welcome you, ma'am.
So now I hand over the session to a very dynamic and academician, Dr. Mitra Saxena, ma'am.
Thank you so much, all you wonderful people. Like, it's really a great time. So I really actually feel that these academic exercises, if they're done in the right spirit, they they increase the academics of everybody. Like Dr. Bindal said now that she jumped on the opportunity to prepare this talk. So similarly, when you do a panel or you do talks, and then you sit and listen to all the speakers, it's great, learning. So frankly speaking, friends, I have to appreciate the Synergy Club, which is a brainchild of Monica and all the like-minded people, and you all are doing phenomenal work. This is not my first time. I think this is my third time I'm participating, and thank you, Monica, for always keeping me in your mind so that I'm there, and I love academics. That is quite obvious. So I have Binu and Dr. Juhi as our experts. I would like to tell you something that I have purposely not taken it as a case-based management, because we all know that whenever there are multiple etiologies and multi-organ failure possibilities, we will always be resorting to help of our colleagues. So as an obstetrician, if we are in a single setup, what we should be equipped with, what are the steps to resuscitate with, Binu is actually told very nicely, but we'll break it up. We'll let our panelists answer those questions. Padma will be moderating it. I'm just here to, जिसे कहते हैं ना, कंधा लगाने के लिए. And we both bring you greetings from Rewari. Come to Rewari and enjoy our hospitality, all from Bhopal, Gwalior, Agra, Dr. Amrita from Gorakhpur, and I could see from Agra also. So all of you all are really, we love to play host to all of you. So I know, but I was looking at the CV, so I know the people from other cities are from medical colleges and bigger centers, but all my society people, I may let you know that they are all standalone practitioners. So that is the story in a small city, tier 2 city, that we are all managing our patients on our own. So I think this panel is aimed at kind of revision of what we have all heard, and also be prepared, because not always everybody will be lucky like Binu. Okay, most often we may lose the patient, we may lose the children, child, baby, but then what to do, how to document. So with that in mind, our panel will be conducted, and I welcome you all. And I hope the experts, whoever are there, especially Binu and Juhi, and Dr. Bindal, if she's there, Dr. Amrita, please stay tuned so that you can give your inputs as well. Now, when we talk of the word sudden obstetric collapse, sudden means it's like a bolt from the blue. It is unannounced and unexpected. Obstetric is anything pertaining to a parturient lady. So she can be early pregnancy to as long as postpartum 6 weeks. So even an early pregnancy patient with ectopic rupture could be collapsed, or she could have any intracranial, etiology can be very varied, but because she's obstetric, she's a pregnant lady, she will be classified into a sudden obstetric collapse. And when we say collapse, we mean that she has lost her consciousness, which could be temporary or it could be quite sinister, with or without fall in the vitals. So the main 3 vital organs that can be, to be managed simultaneously are the cardiopulmonary status and the cerebrum. So our management has to be discussed in the line of these four most important things. First is it has to be recognized very early. The earlier it is picked up, not all the time we will be by the side of the patient. So our staff has to recognize the junior residents or the nursing staff, and then how quickly the resuscitation starts. Then, of course, like Binu has already mentioned, simultaneously the team lead. Now, if it's a senior obstetrician or a standalone practitioner, they have to mentally keep on assessing what is the diagnosis, what's wrong. And while resuscitation and all the steps that have already been told, that is being done, in our mind, we have to understand what are we going to document, what are the dialogues we have to speak to the patient and our to the assistants and the family and the whole team. So this has already been covered in detail, but we'll again reiterate that our eminent panelists will take it one by one, because many times we have people who log in late. So over to you, Padma.
Thank you, ma'am. First of all, I would like to say it's an honor and pleasure to moderate this session with you. I welcome all the panelists and our experts. So without wasting much time, we'll just start on with our questions. So first of all, let's just recap what is maternal collapse. So I would like to request Dr. Amrita to please tell our audience what is maternal collapse.
Is Dr. Amrita over there? Or whoever wants to take it, like it's that is
Dr. Amrita Jaiswani.
Dr. Amrita, are you there? She's logged in.
She's logged in.
So whoever would like to say, Dr. Charu, you can say, anybody.
Yeah, it's actually an acute event where it is the mother who's undergoing a cardiopulmonary or a cranial event, and she's losing her consciousness. It may be with or without loss of the vitals, and that's the basic. It's basically, as already ma'am told, sudden obstetric, and it's a collapse.
So basically, what we are afraid is that the woman should not die. So the quicker it is recognized, everything starts off right away.
So maternal collapse is actually not a very reported event. So the true incidence cannot be estimated, but it could be as high as 6 in 1,000 births. So, but it has been seen that wherever death has occurred in such cases, poor resuscitation has been a recurring theme. So this point really needs to be emphasized here, that the team has to be trained. Everybody should know their roles, and we should keep on moving and doing according to the protocols. The most common causes that we have seen for a collapse are vasovagal and epilepsy. Obviously, most cases are unpredictable, but they can be predicted if we know some of the history of the patient, the high risk factors of the patient. We'll see all these one by one in detail. And we should also be knowing about the physiological changes of pregnancy, which can pose a challenge in the diagnosis as well as the management. So we'll have a look at these as we go further. So now I would like Dr. Anubhuti to please explain what are the physiological changes in pregnancy that can affect the cardiopulmonary resuscitation in a case of maternal collapse. Dr. Anubhuti?
I must tell you that Anubhuti is a young, dynamic obstetrician, very competent surgeon, and in a standalone practice. Yeah.
Thank you. Thank you for those sweet words. The main important physiological changes, as all of us know, that there is a gravid uterus that is present. So the demand of the in pregnancy in whole is also increased. And also because of the gravid uterus, it pushes the diaphragm upwards. So the capacity of the lungs also decreases. The IVC compression is also there. So the return of the blood flow is also less. So these are the main things that we need to take into account whenever we are dealing with a collapsed patient. Because what we mainly deal with is the airway, the breathing, and the circulation. And all these three things are physiologically compromised in a gravid uterus. So this is the main part. The rest, I think, ma'am will explain.
Thank you, Dr. Anubhuti, for explaining it so well. So we have seen that from head to toe, there are changes in our pregnant patients. So we need to be aware of them. We need to know how can we conduct a CPR, what will be the difficulties in conducting a CPR, and what will be the effect of a gravid uterus on aortocaval compression, what's going to be the effect of the physiological changes in blood that takes place, the dilutional anemia that is there in the pregnancy. So we have to take all this into consideration when we are resuscitating a patient of maternal collapse.
So these things, no, already, which this slide is very, very important because it tells you head to toe. So enlarged breast, laryngeal edema, reduced tone. These are things that if we are resuscitating a patient who's pregnant and to intubate her with a high risk of aspiration. So this is something which can compound the complications. That is why this slide has been introduced. So I hope that if anybody is interested, they can take a screenshot and then we can take it ahead. So already Dr. Binu, Dr. Anubhuti and Dr. Padma have reiterated that these are the challenges when we are resuscitating a pregnant lady.
So now comes a very important question. Can you identify which patient is at risk of a collapse? Can you predict beforehand? Can we or can we not? So let's go to Dr. Charu Mittal to answer this question. Dr. Charu ma'am, please tell us if identification is possible in such cases.
Yes, we can at least anticipate in some of the high-risk patients, like especially if we have a PIH patient or an anemic patient, or where there's a big uterus, like in twins, polyhydramnios. Even IVF pregnancies are known to be more prone for complications like obstetric collapse, as Dr. Binu had just spoken in her talk also, that patient collapsed. So previous Caesar also, because there can be a risk of scar rupture. So we have to be, again, be very careful in these patients. So there are certain high-risk things we have to keep in mind. And we can triage the patient accordingly, that this patient is more at risk.
So all those
there can be history
cases,
of drug allergies also. Sometimes patients give us history of drug allergies. So sometimes there may be risk of anaphylaxis if unknowingly that drug is given.
Very right, very right. So basically, what is very important is the history of the patient and the present pregnancy and the past history, past drug allergies or anything, and presently also, and especially in previous cesarean and induced labors, we have to be cautious because there can be sometime everything fine, but we have to not forget amniotic fluid embolism, which can happen. So very rightly you have said. And as you have also mentioned IVF conception, and in my own, learning, I have realized that in antenatal period, if the patient complains of breathlessness, even in the first trimester or second trimester, please do not be in a hurry to brush it aside. All these things are pointers to having a safe confinement at the last. So never miss the window of opportunity to rule out a cardiac or a respiratory cause or whatever. So I think Dr. Charu, you have enumerated almost everything, right? So we can go ahead. Thank you so much. Lovely.
So this was basically can we identify. Now we'll go to some more specific things. There are some etiologies, there are some causes, there are some disorders that can cause this post-maternal collapse. So let's enumerate them. So I would request Dr. Divya Yadav to kindly enumerate the causes of maternal collapse.
Dr. Divya, are you there? Not able to see. If Dr. Divya is not there, anybody could take this, but this is straight away a direct question from RCOG guidelines.
Can I take, ma'am? Can I take?
Please. Yeah, ma'am. Naam bata do, please.
Dr. Nidhi Bansal from Agra, ma'am.
Thank you, Dr. Nidhi. Yeah, please.
Ma'am, it has been already told by both of our lecturers that there are two types of causes, 4H and 4T. One is hypoglycemia, hypothermia, hypoxia, and hypovolemia. More common is the 4H, and 4T is mainly thromboembolism, tamponade, toxicity, and tension pneumothorax. And other than this, obstetric causes like eclampsia, sepsis, and hemorrhage. These all are related to the causes of maternal collapse by the RCOG guidelines.
So my personal take on this is why we are emphasizing is that this as a screenshot should be somewhere on your desk somewhere, because these things will help you when you have to document, complete your records. So हमारे दिमाग में एक दो चीजें ही आती हैं हमेशा, amniotic fluid embolism आता है या मतलब DVT pulmonary embolism आता है. We don't think of other things. Hypokalemia, hyperkalemia, metabolic acidosis, these things don't come immediately in our mind, but they could also be, doing some problem. So basically, we have this chart on our laminated somewhere in our labor room or on our desk. It'll help us in, composing the documents. That's why I thought we must, emphasize importance of this chart. Chalo. Thank you. Thank you, Dr. Divya.
Thank you, ma'am.
So now we have one more thing, the postpartum collapse. So there are some few conditions that are specific in the postpartum period. I would just like to enumerate these lists, like postpartum hemorrhage, pulmonary embolism, amniotic fluid embolism, some cardiac events, intracranial events, and drug overdose and toxicity. These are specific to postpartum collapse.
And also, Dr. Padma, Dr. Bindal had pointed out acute inversion.
Acute inversion.
So
yeah,
if it
right.
is not diagnosed, suppose it is not totally out of the introitus, but patient is in neurogenic shock. So anybody would like to answer this trick question? In neurogenic shock, what is it that kind of clinches the diagnosis just on the vital signs? Anybody? An extra chocolate for that.
Ma'am, the pallor will not be corresponding because they would not be having so much blood loss, but the shock will be out of proportion to the anemia. Means she's not anemic most of the times.
So without, making it a big thing, in acute inversion, because it's a severe neurogenic shock, BP will be low, but bradycardia will be there. She will not
Bradycardia
have
with
tachycardia,
hypotension.
right?
Bradycardia with hypotension is generally
Yes. So actually, these little things we remember from our textbook, then we remember from our patient's scene. And suppose somebody just comes, always inverted uterus bahar to nahi hoga na. It could be complete inversion within the vagina, and patient is in acute shock and unconscious or in severe pain. She cannot. So the clinching point is bradycardia and shock, and of course followed in delivery. So we should add that.
Yes, we should
So
add that.
thank you. Dr. Bindal had pointed it out, but I was not able to add it. Never mind. Thank you.
Thank you.
Then let's go on to
Ma'am,
the
less than 50?
Sorry?
Bradycardia, that is less than 50.
Yeah, bradycardia, of course, inappropriate to the pulse, inappropriate to the blood pressure. That's what it is. For example, if the BP is low and the pulse is also low. Understand? When we are suspecting hypotension, we are expecting corresponding increase in the heart rate. So if we are finding that the heart rate is not gone up, but the BP has fallen, patient is unconscious, followed by delivery, first thing that comes in our mind is acute inversion.
Thank you, ma'am.
Now that we have covered our causes, it's important for us to know that can we identify that a patient is going into collapse? There must be some warning signs. There must be some criteria. There must be some score. So let's ask Dr. Kiran to please enumerate the modified early warning obstetric score. Dr. Kiran?
Shweta is there. Shweta?
Yeah, hi, ma'am. Yes, ma'am. We have a score to identify to understand the urgency, we need to take the action. There's a modified early obstetric warning score, and in which we have some criteria like systolic blood pressure, diastolic blood pressure, respiratory rate, and the pulse rate, and the urine output, and the consciousness level of the patient. Then when we ask the patient, we question the patient how she respond to the voice or to the pain, and based on these criteria we give numbers, and if the scoring is more than 6, then there's urgency and the patient needs urgent action. And we have color coding also for that: green, yellow, and red. And red means immediate action is required, and green means normal, continues the routine care, and the yellow part means we have to be alert and inform our senior, and the emergency team have to be on the standby.
Anup, Shweta, I know you're in a standalone practice. So, who do you think is supposed to do, who has to be educated about Meos in our kind of setup?
Ma'am, firstly, the staff who
Firstly,
is
नहीं वो ही
handling.
होते हैं अपन तो सारे टाइम होते ही नहीं ना तो all
Staff,
our
the
staff
staff
has
is
to be
taking care of
educated.
the
I know it.
patient.
You have educated all your staff, and then how do you manage it in your setup? Please tell that as well.
Ma'am, we have the staff knows what is to be seen, and the first thing is the consultant is to be informed, and second thing is if I want to call my seniors like you, most of the time I'd call you and my friend Dr. Padma. So the seniors and the colleagues need to be called for the help, and all the ABCs of the criteria, the resuscitation ABC criteria has to be followed, and the anesthetist has to be called, and
Yeah. Okay. I will just say what I really also wanted. So because we who are in single setups, so like we have monitors in my own setup, Shweta knows it. We have a multi-para, and the staff keeps taking all the vitals every 15 minutes and posting it on our WhatsApp. So that is one way they keep doing the monitoring, and we also know. Another thing that I want all the audience to pay attention is that there is midpoint, the score should be low. So 0 means all normal. Higher and lower, both are sinister. So as Shweta has rightly said, that the color coded is red, amber, and green. So green is good to go. Amber is be warned, and red means immediately the senior and the whole team has to be called. So basically, all our panelists who are in bigger hospitals, they have a very big team of staff and their residents, junior residents, so many layers. But for all of us, like who are single units, I think having a multi-para, all post-op patients, and continuous monitoring every 15 minutes, they take a picture and send. That's my way to stay safe. And I'm telling
We
you,
should all adopt that.
post-operative is the maximum, as very rightly Padma had mentioned in the first go, that it is inadequate resuscitation at the first, time that we lose.
The initial time that we
Initial
lose.
time. So for that, they have to be taught. All our staff, our skilled, unskilled staff needs to know. Okay, let's go on to next. Yeah.
Okay.
So basically, dear panelists, although everything has been told by Dr. Binu, but we want that you break it up. One panelist will take resuscitation for the circulation, one will take for the airway, and one will take for the breathing. Okay, and then, so that's why we would want, so that the audience are there, they will be benefited. So whoever wants to take this, please.
Is Dr. Monica there? Dr. Monica Jain?
Dr. Rashmi, she's also.
Yes, I am
No,
here.
she's also there. Anybody else? if you
Dr.
want to
Rashmi,
take
aap
this
bolaiye.
question?
Yeah, first we see the initial response of the patient. With response of the patient, we call for help, initiate code blue, and then look for the pulse of the carotid pulse, the breathing of the patient. If the patient is breathing and there's no pulse, then we do immediately CPR. And CPR, and if the breathing is also not there, then we give CPR 100 to 120 compressions per minute, and with 30:2 ratio, we do that. And in pregnant women, we push the uterus to the left, and that is, I think, and we call the team.
So basically speaking, Dr. Rashmi, I would like you to highlight how the chest compression, which is the first thing is, we used to be taught ABC, airway, breathing, circulation.
Yeah.
But now it has totally changed. The first is circulation. The minute
First
you
is chest compression.
diagnose that the patient is not responsive and there is no pulse or whatever, you don't even wait. Whoever is there will give a chest compression and start the chest compression. So please highlight the procedure for chest compression alone. Then we'll take somebody else to do the other.
Ma'am, first we push the uterus to the left with the two hands, one palm over the other with the fingers interlocking. You give pressure over the sternum, midpoint of the sternum, and it should be about 5 centimeters, 5 to 6 centimeters down, and we should give the time for the chest to recoil back. And over 100 compressions, we give 2 breathing, this thing. And that's what I think, ma'am.
So I think that is very
And we should
nice,
have
but
4 BLS persons there. So
Yes.
because one gets tired, so the other one takes over. And one
Yeah.
cycle is of 30 30 compressions with 2 breath sounds. So after breathing, after every cycle, you interchange immediately.
So, ma'am, Charu, would you like to add something to the points of compression? Although she has said everything, but there are 2 things I still want. So,
Ma'am, we should try not to interrupt at all, means it should be a continuous thing. We should not give any gaps. As well as then by the time we have to start preparing for the next step, having the perimortem cesarean ready, means we have to give an instruction to any of the staff because we do not know. We have to give only 2 minutes for this. So within 4 minutes, we have to take that decision. So simultaneously, I mean, things have to proceed.
So actually what I wanted to be added in the chest compression itself is that your elbows have to be straight totally.
The elbows have to
And
be-
second thing is that the patient should be on a firm base.
Yeah.
Okay. So if the patient is on bed, so when you press, it goes down. So these are small technical points. The minute you see that patient has collapsed, ask your assistant or somebody to put her on the floor. And then you start, and you have to be on a little bit of height. So these 2 things seem to be very, trivial, but they're not descriptive. They are real. आपने अगर firm surface पे patient नहीं रखा है और आपकी elbow straight नहीं है और आप कर रहे हो तो आपका ineffective chest compression होगा. So these are the things, and basically I am sure that all of us have been trained with BLS and ACLS. Still, if we keep these things in mind, अगर अकेले फंस गए ना तो ये बातें बहुत जरूरी हैं. सड़क पे भी देना पड़े ना, यही प्रिंसिपल करना है कि immediately chest compression effective होना चाहिए. So that's very nice of you, Dr. Who answered our question? Dr.
Rashmi.
Charu and Dr. Rashmi. Yeah. So now, second thing is chest compression we've done. Of course, if you have a whole team and Code Blue, you say, then the whole team knows everything. But we are alone and we don't have people, so we have to train and let us see what role we assume. But whoever does the chest compression has to make sure. Now, the second thing is about airway. So somebody take the finer points for airway. So compression, airway, breathing. Now let's come on to
Airway.
Whatever Rashmi has said is absolutely in order. 30:2 that we have to do. Now let's come on to the chest compression. Chest compression, she said,
Airway.
so this is the diagram that it has to be, where it has to be placed. Patient should be on the flat and your elbows should be straight. That's why I said that already has been done very nicely. So nothing has been missed. And basically, when we are going to train our staff, we have to make sure that our team is fixed. कि जब अगर कोड ब्लू कहेंगे तो कौन लोग आएंगे फटाफट और कौन कौन क्या क्या करने लगेगा. Okay, so this is wait 1 second. Where is that airway? Yeah. So I'm just sort of slides.
So after we have started CPR, we have taken care of our circulation. The next step is to secure our airway and breathing. So Dr. Nidhi Bansal, if you would like to tell us how to secure airway and breathing.
Yes, ma'am. Firstly, put the patient on the flat surface. We have to tilt her head and lift her chin and make a little bit thrust on the jaw so that the airway could be open. But it is difficult in pregnant patient because there is laryngeal edema, breasts are engorged, and there is a difficulty in intubation. We have to intubate her if there is no response. First, we have to do bag and mask ventilation. If it after some time, and then we can intubate her with the endotracheal tube with the cuffed air.
So actually chest compression, airway, all these things are being done to be done simultaneously, but we are just breaking up for the audience to know the airway has to be extended so that the tongue, and we have to avoid the tongue falling back, and we have to make the airway in a proper thing. And
we have to use 100% oxygen.
Oxygen,
Because the
yes.
fetus extracts 25% of the maternal oxygen. So
Yes,
that is why we have to use 100% oxygen. And we should think about intubation very soon. and
Yes.
should use a cuffed endotracheal tube in such patients.
Yeah.
Okay.
So,
And after advanced airway has been placed, we should monitor it with ET, and we should establish that the effective airway and breathing has been secured.
So if we have given effective chest compressions and secured airway, and of course somebody would be monitoring the pulse oximeter and the blood pressure, whatever. And if we get circulation, we are very fortunate. Otherwise, also we have to continue it. So now let's go back. We have to go back, no? We go back to the uterine displacement. Yeah. So this has been very beautifully highlighted by Dr. Binu, but somebody again reiterate, will be good.
Juhi, you can participate wherever you want. I did not hear Juhi.
Sorry?
And Juhi Agrawal is our expert and she's a very
हाँ तो
brilliant.
मैडम बताएं, डॉक्टर जूही बता देंगे ना या
Madam is doing her job so well. I need not
नहीं
interrupt.
नहीं नहीं जूही listen. This is all, we are all like kind of a round table, right?
Yeah,
मैं
I
और
know.
पद्मा तो साथ ही हैं, but आप भी हमारे साथ हो, तो आप please take up, आप अपने input जरूर दीजिए without any hesitation, please.
नहीं बिल्कुल, everything is going on so well कि मुझे ऐसा लग ही नहीं रहा है कि I need to interrupt.
Okay, so now the next question that arises is.
मैं एक बात बता दूं, ये जो single hand और two hand है, इसमें सिर्फ एक बात है कि if you are standing on the right of the patient, you have to remember that the uterus has to be shifted to the left so that it is displaced from the inferior vena cava. So if you are on the same side, you're just one hand pushing is enough. If you're on left side, then you push it towards your side. That is all there is to about the single hand and two hand. So it's nothing to do with what is better, what. Idea is just to
you are
deviate the
standing in
uterus to
relation
the
to the
heart.
patient.
Yes, yes. So this is our message. Dr. Binu has taken the left-sided algorithm in very beautiful way. We're not going to, spend more time, but this is our message that all OB-GYNs and their staff should be trained in BLS, ACLS, and the drill should be practiced at regular intervals. And Dr. Monica, as a treat, will share the beautiful emergency drill video, and you all will inform us that we have done it in our units. Okay. So we've done all this.
We have seen all this.
Yeah. So of course there is a trick to hold the mask. So somebody would like to say, Dr. Juhi, aap bata dijiye, please.
Yeah, it should be snugly fit, covering the mouth and the nose. And see, here you can see in the picture how this mask is being fitted over this mouth, and the neck should be extended as the same as it is the same position as the intubation was done, because because of that position the airway becomes straight and the air goes directly into the lungs. That is the reason that you should always remember this, and more so in pregnant women. And now after you have completed your resuscitation, that is 30:2, here what you can do is you can give 110 breaths per minute, and for every breath for 6 seconds with continuous chest compression now.
Yeah.
Now there is no rule of 30:2. Continuous chest compression is to be given along with the breaths.
So it means basically the message for all who are going to be in the team of resuscitation is for 4 minutes, you have to make sure that the compressions keep on and on, intercepted with every 30 compression, 2 breaths. So whether it is by bag or mask, so that is why you need a team which can rotate. So one person is doing the chest compressions, the other person is doing ventilation, and they rotate in an anti-clockwise direction so that nothing stops. That is the most important thing. And you know what? When we are answering a question in a theory or like this in a panel, it's very simple. We will not miss. But the problem is this, that when we do it in a drill fashion, also we make mistakes. So imagine कि अगर real time में एक patient unconscious है where obstetrician is half dead. I can tell you, obstetrician should not be the one to do the compressions. ये मेरा एक आप लोगों को message है.
Madam, chest compression is very tiring. It takes lot of force. Chest compression
Not
is
only
very
force,
tiring.
you know, we are the leaders, so we should think next क्या करना है, हम notes क्या लिखेंगे, हमें कैसे manage करना पड़ेगा, obstetrics क्या करनी है, let others of your team do it. तो इसीलिए ये drill करना बहुत बहुत
Very
जरूरी है.
important. It is very
Everybody you know should be having a team. कि आप 2 जने चेस्ट कंप्रेशन लोगे, 2 जने रेस्पिरेशन करोगे, एक जना भाग के डिफिब या कुछ ले आएगा, ड्रग्स ले आएगा, क्रैश कार्ट ले आएगा, तो everything has to be arranged. So that is why it's really important, क्योंकि उस समय हम अधमरे हो जाते हैं. जब मरीज का SpO2 डाउन आ रहा होता है ना, we know we are losing, तो हम तो सिर्फ रिससिटेटिव हिस्टेरोटमी करने के लायक होते हैं. समझ गए, ये मेरा अपना पर्सनल वो है.
मैडम मैटरनल कोलैप्स हमें कोलैप्स कर देती है.
हाँ बिल्कुल बिल्कुल सही कहा है. और आप लोग तो मेडिकल कॉलेज में हो, तो आपकी तो टीम है, एक आवाज से पहले लोग इकट्ठे होते हैं, आपको बाद में बुलाया जाता है. यहाँ तो हम ही सब कुछ है, हमें सब कुछ करना होता है, और ऊपर से तारे दिख रहे होते हैं कि क्या होगा. So let's talk about defibrillation. So who would like to take that question?
Dr. Raj Kishori, are you there?
Anybody?
Good evening, ma'am.
Who's answering it? Please let identify.
Ma'am, Dr. Raj Kishori from GR Medical College,
Yeah,
Gwalior, ma'am.
please करिए आप तो.
Welcome, Dr. Raj Kishori. Dr.
Thank
Rashmi Agarwal is also there. She's not answered, no? Yeah.
Who?
Rashmi Agarwal. I can
Rashmi, Dr. Rashmi has answered. Dr.
अच्छा.
Raj Kishori, आप बताइए.
Okay, ma'am. The defibrillator is a lightweight, portable, computerized device basically, and it used to identify the lethal rhythms of the patient, and it delivers shock to terminate the abnormal rhythm of the patient. What we are supposed when the patient is collapsing, we have to arrange the defibrillator, and the rescuer will be attaching the pad to the victim, and after that the operator will clear the field before analyzing the rhythm, and then when they are delivering the shock, they will be clearing the patient. They will say I clear, you clear, and all clear, and then they will deliver the they will on the shock button, and they will deliver the shock to the patient, and with the help of this the abnormal rhythm will convert to the sinus rhythm.
One thing I would like to add,
Yeah,
in
please.
pregnant women, the position of giving shock varies at times. You have to give, since because the breasts are very large, there is an enlarged uterus, so you may give this shock in anterior and posterior pericardium also.
Okay, yeah.
Position may vary. It may not be always lateral. It can be anterior and posterior pericardium in pregnant
So
women.
actually it has simplified the automatic defibrillator. It analyzes what is a shockable rhythm and what's not. So please correct me if I'm wrong, all who are, you know, professors and teachers, that what I have understood is that if we are getting ventricular fibrillation, you can give the shock. But if it is asystole, then, you know, I don't think that the shock is going to help. Or please correct me. What is the concept? So it has to be a shockable rhythm, means that it is ventricular fibrillation. है ना?
Pulseless ventricular tachycardia also.
हाँ,
Like
tachycardia.
ventricular
and-
tachycardia, but that is pulseless. We're
हाँ.
not getting peripheral
And
pulses.
cardiac
into that.
asystole may not respond. We may have to do.
Yeah, the asystole is not recommended for this.
Yeah. So that is important. मतलब कि कौन सी वाली rhythm shockable है, कौन सी नहीं है. ठीक है ना? So very nicely you have
Also,
explained.
one
Please add.
small point, that the energy to be used in pregnant patients is the same as we use in
As we use in the non-pregnant.
There's no change in the energies.
Yeah.
And it is absolutely safe for the fetus, so we should not hesitate to use it if we need to.
But as Dr. Binu has said that PCMS should be simultaneous procedure. We have only 5 minutes. So we have been resuscitating the patient. Meanwhile, we have to remove the baby as well. Because the circulating volume will increase as high as 30 to 40%. The moment you remove uterus, the moment you remove placenta, the volume of blood increases suddenly. So the resuscitation becomes more easy. And,
So basically the cycle is very, very simple actually. 4 minutes, and when you see a patient collapse, your assistant should have got the tray. कि कब जरूरत पड़ जाएगी, तो let's be ready. So within 4 minutes that has to be done. So 1 second to बात करो. Hello Anshu.
So yes, now
फिर
next
अभी
we'll
मैं खाना
discuss
कर रही हूँ, फिर बाद में
that
बात
what are
करेंगे.
the drug therapies that can be used during resuscitation. Dr. Renu Jain, are you there? Ma'am, can you please answer this? Or anybody else would like to answer?
मैडम डॉक्टर चारू आप बता दीजिए.
Basically, we'll have to maintain the. So there is basically epinephrine, which is the drug, emergency drug to be used immediately, the first one, and it can be repeated to a maximum of 3 doses every 3 to 5 minutes. If that is not working, then even amiodarone is available. So that also is a emergency drug which can be used in this condition.
In ventricular tachycardias.
So what we have to remember, thank you, Dr. Charu. We have to remember that we don't have too many drugs to remember. अगर ठीक होना होगा तो वो मतलब पेशेंट जो है आपका एपिनेफ्रिन से ही आ जाएगा, है ना. शॉकेबल रिदम है तो you are on a better plane. Otherwise, epinephrine. And the other thing you would want to tell about where to place the.
That should be about.
Madam, there is one more drug now. I mean, even I have heard for this time intralipid infusions in case of anaphylaxis.
Anaphylactic shock.
Yeah.
I have not heard. I mean, I have never practiced it, and I have not.
Sorry.
Intralipid infusions.
Actually, I'm not able to hear. Come again.
Intralipid infusions for
Yeah. We will tell that.
Case of drug toxicity.
नहीं, अगर xylocaine sensitivity हो जाती है, which is a reason for sudden shock. We have seen that a patient of IND was given xylocaine and immediately patient went into shock. So the only way to save the patient is intralipid. That is why in those who have got their NABH recognitions, they will have intralipid in their labor room and in the OT. And I, as a precaution, हम तो single handed हैं, तो हमें सब कुछ छोड़ के चलना चाहिए. मैंने तो पिछले 15-20 साल से मेरे लेबर के पेशेंट आते हैं, उनको xylocaine टॉक्सिक सेंसिटिविटी भी कराते हैं, क्योंकि क्या होगा ये नहीं पता, पर कम से कम मरीज को पता है कि ये टेस्ट डोज लगी हुई है एंटीबायोटिक की, ये टेस्ट डोज लगी हुई है xylocaine की. तो we should be safe. That's my learning, because the price to pay is
a feature in medical college.
तैयारी तो पूरी होनी चाहिए, फिर कुछ होना.
See, medical colleges are doing everything in order. When you translate your practice into private, there are a lot of, cutting the corners, but some things one should not. So, ye hai. Let me know who brought in the intralipid. Thank you so much.
Madam, actually, I was going through the literature, and to be very honest, I have never seen intralipid. What is intralipid? How does it look like? What does the vial look like? How does the vial look like?
Madam, it is available. मैं उसकी photo डाल दूंगी. हमारे OT में है intralipid.
Personally used it. That is why. That is what I want to stress.
Mitra ma'am, can I please welcome one guest who is also very, very dear to all of us, and she's a guest of honor, Dr. Rachna Dubey Agnihotri.
Oh, yes, of course. Welcome to
Hi.
Rachna.
Good evening, everybody. I'm sorry I got delayed. I had a terrible meeting which got delayed, but I don't want to disturb anybody. Thank you, Monica, for making me join here. And I was just, for the last 5 minutes, I was very much into the discussion, and I was hearing to this beautiful discussion. And Juhi, even I have never heard of this. And if it is being practiced in private, then intralipid infusion is something new. But how it is to be used and how it is to be done is really to be discussed and conveyed to the audience in a very nice way. And I don't know how many people are there on board, but Dr. Juhi, Dr. Charu, Dr. Mitra Saxena madam, I think there's nobody else over here. Thank you very much for making me a part of this synergy. And Monica, of course, she is one of the most hardworking persons. I was talking to her the day before yesterday, and I was asking her, Monica, तुम इतनी मेहनत कैसे कर लेती हो कि तुम synergy भी organize कर लेती हो और अपनी conferences भी कर लेती हो और मरीज भी देख लेती हो. So she needs to pump in some energy to all of us also, so that we are smart enough to manage all these things together. I would like all of you to please continue, and I want to come in between. Thank you very much.
Thank you.
Rachna, आप अपना video तो on कर दें, लोग, people to see how beautiful you are.
She's Meera madam's daughter.
I know, because my best friend is Dr. Meera's student, so I know Rachna for many years. Yeah. ये
So-
याद रखे ना रखे, हमें याद है.
नहीं,
What
how
I
can I
wanted
do
to
that?
tell about intralipid is pediatricians use it very
Oh,
often. So
Madam,
it's
we
not
also
something
use
which
it
is
in
not
IVF.
available.
It is also
Sorry?
used to feed, I mean, to supply calories in case of
Madam,
post-surgical.
Yeah, it's the
Madam,
same, 20% intralipid. It is available in neonatology units. So it's not
Okay.
something which is unheard
know.
of. And I think, we had to keep it, and I had read about it. क्योंकि वही है ना कि
Madam,
be
it can be
cautious.
used in any sort of anaphylaxis. I mean,
Julie, I wanted to speak on intralipid, madam. It is a
हाँ,
very,
बोलो.
very common adjuvant in IVF. In IVF, intralipid bottles are carried by the patients and they are given after embryo transfer, just in those cases where there is recurrent implantation failure.
yeah, I have gone through this also, Didi, today.
So it combats the immunological causes of infertility.
Immunological.
But having said that, we are sometimes scared that intralipid itself can cause some sort of anaphylaxis.
Yeah.
So whenever we give intralipid to the patient, usually it is prescribed. I get patients from Mumbai that वहाँ के डॉक्टर ने पाय सर ने बोला है या डॉक्टर पायशेटकर ने बोला है कि आपके यहाँ के लगवा लो. So a lot of adjuvants are not evidence based, but they are just used for the value of that immunological factor.
Intralipid used for xylocaine toxicity is the only antidote. So if somebody is having anaphylaxis to xylocaine, especially when it goes intravenous, then we have no other way to combat but intralipid. So that is a standard of care. As far as like what points Monica has brought in, that is a news, and that's good to know that it is.
Otherwise,
so many
the
other
origin
uses
is
as well.
TPN.
And
Origin is from TPN, total parenteral nutrition. It is a part of TPN.
Yeah, TPN
It's
का
part
है.
of
Yeah,
TPN.
yeah. So thank you, Dr. Juhi, to kind of dissect it open, and it actually adds into knowledge of everyone. So we can all chip in, and then all of us can actually even review and enhance the final guidelines. So thank you, Dr. Juhi. Thank you, Monica.
You are welcome, ma'am. Pleasure
Uh-huh.
is all mine.
Okay, so this question has been taken, but I think it needs to be addressed again. So correct the perimortem cesarean section.
Yes, to resuscitative hysterectomy. Yes.
And whoever would like to speak, Anubhuti, are you there, or anyone?
Should I take?
हाँ, please. जो ज़्यादा आंसर
When we-
करेगा उसको हम chocolate
When we
भेजेंगे.
do the CPR for more than 4 minutes and patient is not responding, then in 5th minute we have to do this restorative hysterectomy. This will help us in resuscitation in such way that it will reduce the aortocaval compression, immediately replenish the blood loss by 30 to 40%, which is going in the uterus and placenta and baby, improve the baby's survival and improve the maternal survival and reduce the demand, and it increases the effectiveness of the chest compression also.
Okay, so I had one case who was of twins. She was at 30 weeks, and elderly woman who had very fulminant hypertension. She had not come for checkup for more than 2 weeks. She walked in, but she was dyspneic and her SpO2 was falling. Because I live upstairs, I was called, and I have my ultrasound room. She was lying. We made her lie over there, and हम कैनुला भी नहीं लगा पा रहे थे और SpO2 लगा दिया था pulse oximeter, and I could see her SpO2 falling. She was having frothing, तो मुझे लग गया ये pulmonary edema है. उस समय पता नहीं कैसे, it was not for resuscitating the mother. तभी अकल नहीं थी कि हमें CPR के साथ ये करना है, पर अल्ट्रासाउंड मशीन से देखा दोनों बेबीज अलाइव थे. हस्बैंड को दिखाया और मैंने उसी समय मतलब पेरीमोर्टम ही लिखा तब तो. I did, and both the babies were saved. By the time anesthetist and all had come, we could not save the mother, of course, but the babies got saved. So basically speaking, we of the yesteryears used to do it to save the babies, but now this is a part. So whether your patient is recovering or not, after 24 weeks, you have to do a assistive hysterectomy to complete your notes even. ठीक है ना? Because you cannot declare the patient before the full 5-6 minutes are over. तो 4th minute के बाद आपको resuscitative hysterectomy दिखानी है. Thank you so much. Let's go on to the next. So this thing is already आप बताइए.
Okay, so what is the recommended tray for a resuscitative hysterotomy? A scalpel with a number 10 blade, a retractor, a pack of sponges, 2 Kelly clamps, needle driver, Russian forceps, sutures and suture scissors. These should be available on all resuscitation trolleys in our labor room as well as in our OTs. So these are the minimum number of instruments that they have to be there so that we don't run around when we need them.
And how would you like to open the abdomen?
And that should be a midline incision.
Midline,
We
yeah.
open it fast.
Yeah. Immediately
We need not go for all that fan and sail incision,
Nothing, yeah.
all the decorative things. Just a simple clear midline incision and just take out the baby.
And give it to the neonate,
neonate.
neonatologist, and close the uterus.
Uterus,
Yeah. So this is a question which has been answered. So I think, Padma, you answer them.
Yeah, so till when to continue the resuscitation, we should know the point. So basically, this decision has to be taken by the cardiac arrest team. And what is important is that we should document whatever has happened, whatever steps we have taken, and all the resuscitative measures have to be spelled out very clearly. And if we have identified the cause, then we should focus on the targeted therapy that we are going to give for that particular cause.
Okay. So we all know that outcome of resuscitation depends on swiftness of recognition, resuscitation, teamwork, but also it is dependent upon the etiology. For example, Binu's case got saved because she was a post-COVID case and, resuscitation was done. And the cardiologist in ICU, she was saved. So now this is the first part of our discussion is over, but we would like to take you through the different etiologies very quickly. So one panelist can take one etiological factor and spell out important key points. We don't want very detailed, but let's just go for
just a brief and a very
so that
concise.
It will be easier for at the time of documentation what our diagnosis should point towards. Okay, so Dr. Nidhi, can you take this?
Yes, ma'am. Venous thromboembolism is one of the most important cause of maternal collapse, and it goes undiagnosed also. It may be, but there are few risk factors which are helpful for us to be knowing that this patient might go in venous thromboembolism. Like patient is obese, she's a case of PIH, severe PIH, advanced age, and she is in after cesarean section. Or is there any other history of the thrombophilia in the family or in the patient itself? It's their history of venous thromboembolism. Suddenly onset of the breathlessness, chest pain, and fall in oxygen saturation, and one-sided leg edema are the clinical features for the patient. And treatment depends on the condition, mainly high flow oxygen, and her airway and breathing should be taken care of. Fluid resuscitation and heparin prophylaxis should also be given in these patients.
Okay, so this already has been taken by Dr. Bindal very beautifully in cases of preeclampsia and eclampsia, especially if a patient has thrown a foot and become unconscious. So what will be the management, Madam? Dr. Rathuchari?
Dr. Rashmi, can you answer, please?
I know.
A patient of eclampsia would give a loading dose of magnesium sulfate, and to control the blood pressure, we may give either intravenous labetalol or hydralazine. And if she's having brain imaging, has to be done for any bleed inside the any cranial bleed if she's having repeated convulsions.
So whenever we are dealing with a case who had PIH or eclampsia, she threw a fit. So the basic management of a convulsing patient, a nurse in the left lateral position, oxygen, and of course, whatever that we are very, eclampsia drill is very much in our mind. Of course, if along with that, she also has cardiorespiratory arrest, we have to do the management of the collapse and simultaneous management of the eclampsia. So let's go on to cardiac disease. Shweta, you are visible all the time. So you are the one who's being asked.
Yes, ma'am. When we have a cardiac issue with the patient in postpartum period, then we need to inform the cardiology team as soon as possible. And according to that, thrombolysis can be given, and thrombolysis is expected to be associated with the increased bleeding from the uterus, from the placental side. And if there is history, then we need to be cautious beforehand also, but peripartum cardiomyopathy can also be there, which can go unnoticed till the delivery. So that can be managed with the cardiology team.
So I think cardiac disease is something which has really, especially after COVID, I don't know how many of you have experienced, but we do have had patients who have come with unexplained cardiomyopathy and sudden compromise in the cardiac functions. So we have to be alert कि इसको PPCM ना हो, कोई इसको underlying cardiac हो ना हो. हाँ, so
respiratory issues.
basically we have to keep this diagnosis in mind, so that when we are writing our notes, we can write advise this, advise this. So this recap is simply so that we know which team to call or where to send. Of course, after the patient is stable.
Madam,
in the
you said
initial-
previously,
Sorry?
that, as you said previously in your lecture, that always remain alert. If at all patient is coming with breathlessness, because this peripartum cardiomyopathy starts at second trimester of pregnancy as early as.
Yes.
So always remain alert. Even if the patient has no history of breathlessness, her hemoglobin levels are okay, but still you should always remain alert that this patient may develop. So go for echo and manage accordingly. Because I have seen many patients going in peripartum cardiomyopathy.
Yeah, delivery आसानी से हो गई और post delivery एकदम से चटक गए.
बिल्कुल, और बहुत बुरे कोलैप्स होती है पेशेंट.
हाँ, बिल्कुल.
फेलियर, बहुत ही गंदा.
So we really have to be, alert. You are very right. Thank you, Dr. Joey. So sepsis, I would like somebody, because this is something which is detected later. बाद में diagnosis बनती है septicemia. वैसे तो डॉक्टर बिंदल ने बहुत अच्छी तरह से लिया था, but still I would say that if this can be reiterated. डॉक्टर अनुभूति या डॉक्टर चारू आप बताइए प्लीज.
Ma'am, basically things have to go simultaneously when we are suspecting a sepsis. So as soon, initially we just take the blood culture, because once we start an antibiotic or a broad spectrum antibiotic, then the culture will become negative. So that's the first step. And along with the resuscitation, which we do with fluids and a broad spectrum antibiotic, we have to send the electrolytes also, because such patients are going to be prone for electrolyte imbalances. And so we have to correct that. Those who are not responding very well, we have to even consider the role of steroids in these patients, because they may have a refractory hypovolemia, hypotension. So I think this is most of the points.
So you're very right. And I am reminded that I had a patient who had normal delivery, and post-delivery, she was only having severe pain abdomen. I was not in station, but my, consultants who were taking care of, they were really perplexed because she had no other complaint apart from pain abdomen. And they did check out, rule out PPA, they did everything. But actually she was deteriorating, and basically in 12 hours, she was so serious that we had to shift her to a higher center, and finally we lost her. But the only thing that was very important in her case was she had anuria and her serum lactate was very high. So I want to say, and when I examined her, her vitals were stable, but her respiratory rate was very high. So RR is very high, lactate is raised, anuria is there. Think of something which is causing multi-organ failure, and please think of sepsis. So, these are important because we may be able to save the patient. We may not be able to save the patient. But at least our documentation should be such that we have thought about this entity. That is why I thought that we should include these case scenarios in our discussion. So thank you, Dr. Charu. Of course, the management, as you have said, but only point is lactate and urine output also, and use of dopamine earlier. Actually, because septic patients may be conscious, so they may be speaking. So they may not classify as a collapse, but they are the patients who are going to die eventually. So I thought it's important that we should have it. Anna, anything you'd like to add? Okay.
Ma'am, one thing I would like to say, in our patients, it is very important to anticipate which patient can land up into sepsis.
Yeah.
So because a patient who is unbooked, uninvestigated, has come into labor to us in active labor or whatever, she would have been in hours in early labor. We do not know. And what antibiotic and all would have been given or not given, leaking per vaginum for a prolonged time. Those patients should have been treated earlier only, so that we can save these patients at least. I think that is very important.
Yeah, very right, Anubhuti. Especially these unbooked patients, I like to call them googlies. because they come unannounced. We don't have, and you ask them their record, they will not come. और ये कहेंगे जी फेंक दिए, and I always ask them, तुमने अपनी wedding साड़ी फेंक दी क्या? Record क्यों फेंक देते हो, है ना? मतलब
Then just come with a single paper,
हाँ,
with nothing written on it.
हाँ, बिल्कुल, absolutely. So bringing this to mind is really important, because we have to ask them कि क्या उनकी कहानी है.
Madam, still abhi jaise it is mandatory we call medicine people whenever the patient goes in sepsis and postpartum period or antenatal period. What they say is total count is raised, so they are sepsis. They are having sepsis. They may be hiding some other obstetric problem which can cause hypotension or feature like sepsis. So what I feel is always go for lactate levels first.
Yes, you're right, Dr. Jui. I'm very happy that you have highlighted, क्योंकि TLC भी कई बार नहीं raised होता. वो
नहीं
जो
होता है, और
classic वो है ना
मैडम
कि we are thinking.
PNC में तो वैसे ही raised होता है.
हाँ,
Pregnancy
मतलब
में
you
वैसे
can't,
it is
हाँ, you
raised.
can't actually rely on that.
Rely on
But
TLC. हाँ.
हाँ, तो सेप्टिसीमिया, मेटाबॉलिक एसिडोसिस, रीनल नॉकआउट, जो कि डॉक्टर बिंदल ने अपने उसमें बताया था कि इलेक्ट्रोलाइट इम्बैलेंस, तो ऑब्स्टेट्रिशियंस की तरफ से हम लोग ना हाई एक्लेम्पसी और पीपीएच पे रह जाते हैं और ये वाले चीजों को थोड़ा सा साइडलाइन हो जाता है. So somebody please discuss this drug overdose and toxicity.
Dr. Raj
Right.
Kishori.
Dr. Nidhi,
Usually, yeah, I can speak, ma'am.
हाँ,
So
बोलिए.
mainly we deal with the magnesium sulfate toxicity. If it is more than 7 or more than 5, then we have to take care of toxicity. We should give 10 ml, 10% calcium gluconate, slow IV in 10 minutes. This is the antidote for the magnesium sulfate. And other thing you have just enumerated, like local anesthetic, like xylocaine toxicity is there. If there is xylocaine toxicity, we should take intralipid with us, and it is the only helpful agent in the local anesthetic toxicity.
Yeah. So that's really good. But one thing I want to comfort all of us is that magnesium toxicity is actually, in my own practice, I haven't ever
Very
seen
rare.
it, because whatever is the prescribed loading dose and the top-ups, they are not sufficient to give it very high, unless, of course, patients' renal functions are
They're already
compromised.
compromised.
So there
And
we
we-
have to be very cautious. Otherwise, it's good to know the antidote, but it's
Ma'am,
good to know that you rarely magnesium sulfate reaches that level.
Yeah.
Yeah.
Recently I have just got a case. She delivered somewhere else in a matlab she got cesarean somewhere else, and she was having very high BP. And we are having our own ICU and everything, and she was referred to us for the management. And she was having a little bit less urine and were hyperventilating, matlab breathless. She was very breathless, and she is in pulmonary edema. And I got her magnesium levels done that were more than 8.
Okay.
So
ठीक है.
that is number.
If
And
you
I
have the
did with it.
facility to do it, definitely.
Yeah.
But I would say that establish renal functions adequacy, perfusion, and urine output, and get and then
Madam,
of course
I
deal
want
with
to add
magnesium
on this,
toxicity.
as
Yeah.
Bindal madam said that always keep for deep tendon reflex. They are very brisk in case of preeclampsia and eclampsia. So
Yes,
loss of tendon reflex is the first thing which you should see, and that is the first sign of magnesium toxicity.
Yeah.
Even if you don't have facility for magnesium levels, you can just check her DTR. If DTR are absent, abundant dose of magnesium.
Abandon.
So that is the first sign of magnesium toxicity.
She was given too much magnesium at their center only, no? Just to
Yeah,
stop the
you're right,
seizures
you're
and
right.
preventing the seizures.
That too with absent, matlab decrease renal flow, renal
Yeah,
output.
the renal output was also less when she came to us, no? Then we got for magnesium test.
Because magnesium is exclusively secreted by renal route. So it
Madam,
gets
Dr.
excreted
Jui,
inside.
what are your instructions to your juniors for administration of top-up magnesium dose?
Whenever they give, whenever the dose is due, always assess deep tendon reflex, urinary output, and respiratory rate.
Yes.
See, they
Yes.
are very much related, because mechanism of action of magnesium sulfate is by relaxation of skeletal muscle at the junction level. So what this magnesium sulfate do? First, it relaxes all the muscle group. So it also relaxes the accessory chest muscles. That is why respiratory rate, to see respiratory rate is very important. First thing.
Yeah.
Second thing, its excretion is exclusively by renal route. Previously, what our residents used to do is they usually give Lasix to increase the urinary output. So now they are convinced that urinary output is adequate, and then they just administer magnesium sulfate. So never ever give magnesium sulfate, Lasix or prompt diuretics to increase urinary output, because it will increase urinary output, but it will not increase magnesium secretion.
Yeah.
So it will keep you in deception that the urinary output is okay. So you may administer magnesium sulfate and it may cause magnesium toxicity. So these are the three primary things, and other things are to be monitored as well. Like you can go for magnesium levels if you have that facility, and so forth. And if you feel that there is magnesium toxicity, you can give calcium gluconate 10 ml. Ampule is available. You just give slow IV ampule to reverse magnesium toxicity.
Very true, Dr. Juhi. And my staff is not a trained staff. So in my setup, the instruction is ki before magnesium sulfate, empty the bladder, tell me empty the urine bag, let me know how much is the output, only then, and the blood pressure. These two
Madam,
things we collaborate and
one
then
thing,
give the max self.
Ma'am, since you manage it single-handedly, one advice, I mean, ho
Yeah,
sakta hai
please
bahut
do.
easy advice ho, but you should always keep a urimeter. I mean, instead of a normal Euro bag, keep a urimeter, because per hour output is more important.
Yeah, it is. Yeah,
Than
I
the total
agree with
output.
you.
Many
Yeah.
times staff, what they do is they say, Madam, 500 cc output hai 5 घंटे में. You never know that पहले घंटे में 300 होगा.
हाँ, हाँ.
है ना, और बाकी घंटों में हो सकता है कम हो. तो this is
That's
the
a
way.
very, very valid and very intelligent intervention, and I'll get back to you for urimeter, because frankly speaking, हम तो वही 4-4 घंटे में ब्लैडर खाली
Actually, madam,
बैग खाली कराते हैं और आवरली लिखवाते हैं कितना हो गया और
No,
फिर
ma'am.
makes it very
Urimeter
simple,
is
madam.
very important, ma'am. Very important.
Yeah.
Urinometer in the bag is very important for early output management in
yeah,
magnesium
that's a
sulfate.
good that's a very good thing. I have
We
to add.
generally take the patient in ICU and then we put the urinometer with Foley's. Then only we manage that patient.
Yeah, so that's a good thing. If you will be able to share the image.
Yeah,
in the group,
I'll
it'll
be
very
sharing
nice.
by tomorrow.
That's a very good thing that you have pointed out, and that is the importance of having everybody is an experienced obstetrician, and you are you have an ICU, so you know
Yeah,
that
ma'am.
aspect. And thank you. So please share the image of this, and
Yeah,
let's
definitely, ma'am. I'll share it by tomorrow, ma'am, when I
yeah.
do the.
So that will be helpful for all. You know, that's thank you, value addition. Thank you. So anaphylaxis is one of those side effects. I mean, those reasons which are correctable, right? So और कुछ ना हो तो anaphylaxis हो, कम से कम हम adrenaline से और उससे save कर लेंगे hydrocortisone से.
Chlorpheniramine hydrocodone, everything is available for that.
हाँ, ठीक है. So what next? Okay, the most important and dreaded complication. Who would like to take this? Amniotic fluid embolism.
I will take it, ma'am.
Oh, sure, please.
Ma'am, this is generally occurs postpartum, after delivery, about half an hour after delivery. And it is diagnosed also by this thing, autopsy, when you find pieces of fetal blood cells or hair or in the lung tissue. The patient will present with sudden breathlessness, hypoxia, restlessness, all these things. The treatment for this is the patient may land up in DIC with severe bleeding. And a treatment is mainly supportive. And maybe we may go for plasma and heparin and all that, depending upon the management of DIC.
So basically, Dr. Rashmi, you have pointed out very important things. Has anybody actually had a case of amniotic fluid embolism?
Yeah, ma'am, I had a patient.
Please
I was
tell us
working
about
in
your
GH.
case.
Yeah, I was working in GH Gurgaon and the patient
One
delivered.
second, let me see who's answering it.
Shweta is answering.
Shweta is answering.
Yes, ma'am. I was working in GH Gurgaon, and there was a patient who delivered 1 hour back, and she was in the postpartum ward doing well. But suddenly, the attendants came, and the patient came to us. We brought the patient to the LR again, and she was gasping. And we saw the oxygen saturation dropping. We started the CPR, and but we couldn't save. And in the post-mortem, in the autopsy, we found out that it was amniotic fluid embolism. Till then, we just had no clue. We knew that it would be embolism, something like pulmonary venous thromboembolism or amniotic, but in autopsy it was confirmed that it was amniotic fluid. It was so patient was not at all having any risk factor. She was not having any PPH, any APH. She was having a slight anemia. That is it. So it was all a very sudden case we had.
Yeah. Thanks for sharing, Shweta. Amniotic fluid embolism, what I want to say is it will be associated with during labor or immediately after labor. So there has to be some precipitating factor for the amniotic fluid to be pushed towards the pulmonary circulation. So even our use of oxytocin, even our doing artificial rupture of membranes, anything can become. So with the scenario of labor ongoing or immediately after labor. So suppose somebody has after 12 hours, we should not write the diagnosis of amniotic fluid embolism.
It
But
was
like
one.
Madam specified that within
30 minutes.
early, within an hour or so after
Yeah.
delivery, if she
But
goes
venous
into this scenario.
thromboembolism can be
Sorry?
Later on also, yeah.
Yeah, venous thromboembolism can occur anytime in pregnancy, postpartum, intrapartum.
So amniotic fluid embolism is those sad things. And I have seen, I don't know, Dr. Jui, that many times patients of IUD or macerated
Yes.
stillborn babies, when they're delivering, and suddenly we haven't given them too much of augmentation, but when they have a strong contraction and they are expelling, they can
Very good.
have this AFI.
Madam, I have seen one during my residency. That was a classical case. I remember, still I remember. When I was in residency, there was a patient with polyhydramnios and we were students. We were always in hurry to deliver the baby. So what we did was we gave her Primifrost. But I still remember, and that in those days we had Primifrost. We gave her Primifrost. The patient was 4 or 5 centimeter dilated. Immediately she collapsed. She went in DIC, acute DIC. We had to deliver the baby, but we couldn't save the baby because at that time, blood and blood products were not so readily available. Only whole blood was available. This is 20 years back. That was classical thromboembolism which I have seen. But madam, I just want to add one thing that whenever you suspect thromboembolism and you make a diagnosis, always ask the patient to go for postmortem because that is going to save you.
Yeah. So you're very right. If you have a sudden death unexplained, you have to write in your notes. You have to insist on a postmortem.
Insist on postmortem.
And tell everybody ki matlab without that. Otherwise, in your documents, you have to put all the provisional diagnosis, etc., etc.
Because
one case I remember was known to us. She was under my mother's treatment. She came at post-date IUD, and she was a 3rd gravida or 4th gravida. And I remember my mother used to not induce, उस समय तो ये कोई prostaglandins थे भी नहीं, oxytocin भी नहीं लगाया था, बस वो just stripping विपिंग करा था, multi थी, that auntie of ours. And when she was pushing the baby, it was a stillborn baby, she collapsed and she died. And only thing is that within her collapsing and her final bye-bye, she started having all the patches of DIC and all. So she was a fulminant case, like amniotic fluid embolism.
That madam, people don't accept, even the attendants, they couldn't realize. So there is always a blanket consent. Madam, when our hospital was Laksh accredited, he took a blanket consent. That is a very good consent, madam.
Sorry, come again, I didn't hear you.
There is a blanket consent.
Blanket
consent for all the obstetric patient that whenever a patient is reporting your delivery room, take a blanket consent that delivery is a process where a patient can undergo cesarean section or initially normal delivery. Anytime if required, cesarean section can be done and there can be risk of pulmonary embolism in each and every pregnancy. So
Yeah.
मेरे
But
ख्याल
Juhi,
से
this blanket consent does not hold true in private setups.
नहीं,
Foxy has also said, you have to have when the patient is collapsing, there should be a junior doctor who's writing everything.
Very true. नहीं, Didi, initially you take blanket consent when the patient enters your labor room. And then when the incidents happen, take it in writing at that moment of time. So there are two consents now.
But
That
ma'am,
is
again, Mitra ma'am, here we come to the medico-legal part that you all are hardcore obstetricians. If every patient who enters your nursing home, you are telling that you may die in labor room of pulmonary embolism.
No, no, no. Actually, we are not doing that, but definitely we are taking according to, suppose if we are doing somebody's cesarean section, then we write the complications, injury to the bladder, injury to the gut, and anesthetic complications, but we don't write the thing of death as in. And in normal deliveries and all, we do write that there can be injury to the rectum, injury to the anal canal, injury, PPH and all. मोटा मोटा लिखते हैं, बट स्पेसिफिकली अगर कोई प्री टर्म है, कोई भी एडिशनल पॉइंट है, वो जरूर लिखवाते हैं. But I get it written by patient's own handwriting. So let's get on to the causes of death.
Polyhydramnios is also a cause of embolism, no, Juhi?
Sorry?
ARM. Polyhydramnios and doing ARM.
Definitely. Polyhydramnios is a very big
cause
kind of situation which can cause obstetric hazard. So when you're rupturing the membranes, there can be AFE at that time, or there can be accidental hemorrhage. So polyhydramnios has to be given lot of respect by obstetricians. Controlled ARM, no hurry. You know?
Yes,
What else?
definitely.
Anything add?
No, nothing is third. But
नहीं,
eruption
one
is
more,
a
one
major-
more, one more. चलो, एक question. Polyhydramnios का ARM करोगे, what are the two things important?
Controlled ARM should be done.
Yes.
And what else?
Look for, be very watchful about cord prolapse and
Cord prolapse.
Cord
Very
prolapse and
good.
sudden hypotension in the patient.
Good, very nice. Because
question, madam, big chocolate for me.
Yes, I will send definitely. क्योंकि हम तो ना examiner बन चुके हैं, हम तो प्रश्न पूछ के तंग कर देते हैं. So definitely polyhydramnios can even lead to cord prolapse and accidental hemorrhage. So we have to give respect to this, है ना? चलो, let's go
Ma'am,
on.
just one thing I wanted to add regarding the consent. The
Please,
Supreme Court in
Aaptariye.
its Supreme Court in its landmark judgment, Samira Kohli judgment, they have said that there is a therapeutic privilege. Less than 10% if there is any risk for any complication, it need not be mentioned, because they also understand you cannot enumerate everything to a patient. So that's our therapeutic privilege. You don't have to write anything which may be less than 10%. Just wanted to add this.
No, definitely. See, the thing is this, between how much to tell and how much to conceal, that is where our wisdom comes in. तो कुछ बताओ, कुछ हटाओ, but अपने लिए जरूर देख लो. If something is a high risk for your own practice, your own setup. मेरा एक blanket dialogue अपने आप के लिए जो मैं सबसे शेयर करूंगी, क्योंकि छोटे छोटे लोग हैं, अकेले काम करते हैं. I tell my patients, like for example, somebody is high risk, है ना? I tell them कि देखो, cesarean is not a big deal. हमने कर लिए बहुत सारे. The place where you are going to get is more important. So I am referring you to a higher center only because they have neonatal facility. ठीक है ना? It's not because it's something great. Cesarean all everybody can do. Sometimes you need extra things. So whatever. So never अपने अंदर आत्मविश्वास कम मत करो. अगर एक cesarean कम किया, doesn't mean that you don't know. But definitely na practice में Dr. Charu, when you are by yourself, every patient is important. उस मरीज के साथ एक और जुड़ा होता है. वो इतने silly होते हैं कि जाके कह देंगे, अरे हमें तो वहां भेज दिया था. You know, so उनके अपने रिश्तेदार अलग हो जाएंगे. तो private practice में बहुत सारी छोटी छोटी चीजें होती हैं. Never mind. So let's discuss cardiac disease.
So main cardiac events could be myocardial infarction, aortic dissection, and cardiomyopathies. So signs and symptoms we all know. There could be central chest pain or interscapular pain, a wide pulse pressure when you measure it, and a new cardiac murmur may be there. So the right approach is obviously to take immediate help of a cardiologist so that we can manage accordingly.
So let's not forget about intracranial events also. So anybody has any case would like to share that?
Yes, ma'am.
Yes, ma'am.
We had
Yes,
a
ma'am.
patient of MI, madam. So she was a
Oh,
patient
please
of
do.
chronic hypertension, superimposed preeclampsia. She had a maternal collapse. Immediately, adrenaline and everything was given, and we found that her tropi was raised and her blood pressure was high. We managed her, we intubated her. She was on ventilatory support for 2 days, and she came up well. So that what I want to say, with increasing rate of obesity and lifestyle changes, we should always predict MI also as a cause of maternal collapse.
Yeah,
Which
we had in the last slide, we had put MI as a cause. Now we want somebody to take intracranial events also, because sometimes in postpartum, I had one patient who delivered normally, but she came after 6 days or something with severe headache. Although she was not a collapse patient, but finally she had had sagittal vein thrombosis and she had cortical vein thrombosis, optical nerve. Finally, she was blind and she was managed as CVA. So as an obstetrician, we can be plagued with problems elsewhere, but because it is related to that event of labor, so we get, involved in the gambit. So I thought that we should put this. And of course, would like to share a case of press?
Yeah, I have also have a case, ma'am.
Yeah, please
It
share.
was like 4-5 years before. A patient was severe PIH, came to us, and I did her cesarean on OT table after spinal anesthesia. There was a little bit blood coming from the spinal needle. Okay, then we did cesarean, all well, patient was okay. But just after 2-3 hours, she complained of severe headache and she was doing abnormal activities like wants to go, she wants to get up. Next day only, I just came, I was all alone and it just came into my mind that I should go for her CT scan. And that then came out to be a press and subarachnoid hemorrhage was there.
The
So she was managed then by
posterior
neurosurgeon.
reversible encephalopathy
Yeah.
syndrome. Yes.
Yeah,
Yeah.
she was the case of press that time only when she was admitted, and I did her cesarean. But all well, that the patient did well, and neurosurgeon did her surgery. Then
As the
only
name
she,
states, it is reversible, but of course,
yeah,
when it happens, you
Yeah,
get
at that
all
point of
tachycardia.
time, we have to not forget that severe headache, severe blinding, or abnormal behavior or abnormal, disorientation. These are all, pointers towards something happening in the brain.
brain.
And so, as an obstetrician, we thought that we should include all the possible things which we can have. And actually, it's a very big learning. We have been, since 5 p.m. I am here because hearing Dr. Bindal, Dr. Beenu, and then reiterating with all of you, adding our own knowledge is really, useful.
Very
So let's come
exhaustive.
on to, I think hemorrhage and APH, BPH, we'll skip that. ये बहुत बार कर चुके अपन, है ना?
Yeah.
Yes.
So let's
Somebody
just,
has an interesting case to share.
if anybody would like to share a case, please tell us that.
Because management and all has been done many
Madam,
times.
one thing I want to add, that whenever you suspect coagulopathy, you should initiate your own protocol as far as blood and blood products are concerned. It may not be 1:1, it can be 1:2, 1:3, 1:4, whatever the PT or INR tells you. So in case of postpartum hemorrhage not due to coagulopathy, you can initiate 1:1 protocol. But if there is coagulopathy, always go for, you can tailor your own need-based tailoring can be done.
So one thing that Dr. Juhi, thank you for bringing it out. I also believe that one very important thing, like bedside test, we used to do clot observation. Hi-fi या elastography पर clot observation शुरू में ही रख देना चाहिए. So we'll know the coagulopathy and fibrinogen levels should be done. They are very big pointer to amount of clotting factors being lost. Right.
POCT gives you a faint idea about fibrinogen levels. POCT, that is the bedside point of care.
Point of care test, yeah.
That gives you a brief idea, faint idea about fibrinogen. So by low resource setting, you can always go for those tests. And
so let's come back to our collapsed patient. So after resuscitation has been done, Padma ordered all her staff to do good resuscitation. She did the resuscitative hysterotomy. Patient circulation returned. So
now I will transfer.
anesthetic is already there.
Yes.
Patient is intubated. and transferred to the ICU, whatever. So now what is very important, Padma, please highlight it.
So now, yes, we can say the take home message or the important considerations are that after all this has happened, the debriefing should be done by the senior most person in the team. And first of all, the team, your staff nurse and the other personnel who were involved in resuscitation should be briefed, so that there is just one version that you are going to tell to the patient and their relatives. It's not that everybody should talk something different. No, everybody has to talk in the same language, the same words. So the debriefing by a senior person is very important. Now, when you're doing this debriefing, we have to be very respectful of the patient's relatives. We have to talk to them respectfully, make them sit and explain it in simple words as long as possible. We should not use very complicated medical jargon, I suppose. We should use simple words that they can understand.
Very good.
And then we should document our steps, step by step. This is what happened at this particular point of time, and then a call for help was at this time. So there should be one person when all this is happening, one who is taking care of the timing. That suppose 7:30 the patient is collapsed. So 7:31 I did this, 7:32 I did this, and for 3 minutes I did this. This type of one person should be there to document all of this, a supervisor sort of person. So this is important. And how will this happen? This will happen when we are doing a regular training of our staff, not just a theoretical training, but a drill. And we should keep doing it, I suppose,
At regular intervals.
regular intervals. We should all
Yeah.
keep doing it.
And I would add this, that all our esteemed panelists who are in medical colleges, they have many opportunities to do it live. पेशेंट ही कोलैप्स हो जाएगा तो ये सब प्रैक्टिस होता रहता है. हम जो कि स्मॉलर सेटअप में हमें तो थियोरेटिकली सब आता है, पर हमारे स्टाफ को हमें रेगुलर इंटरवल्स में ड्रिल करानी चाहिए ताकि उनको याद रहे कि किसको क्या काम करना है ना.
मैडम आप बार बार छोटा सेटअप मत बोलो, मुझे लगता है आप ज्यादा बोल्ड हो आप लोग.
नहीं ऐसी बात नहीं है
भाई. अकेले करना, मेंटली स्टेबल होना एक बहुत करेज का काम. हमारे लिए तो सब चीजें बहुत इजी हैं.
पर ड्रिल्स का हम लोगों जैसे यूनिट्स में रेगुलर होना चाहिए. डॉक्टर जूही, ये मेरा सपना था और है और रहेगा कि ऑल ऑब्स्टेट्रिशियंस इन इंडिया शुड बी वेरी team readiness and facility preparedness. Team preparedness and facility readiness, either with these two are the most important things for managing obstetrical emergencies.
बिल्कुल.
So you all are here with me. We are going to do this in any which ways. आप लोग कर ही रहे हो, हम भी करेंगे, सब मिलके करेंगे. So training is very important, and documentation में like Padma has written, मेरा अपना सिर्फ छोटा सा एडिशन ये है कि जब आप डॉक्यूमेंट कर रहे हो, आपने क्या क्या किया ये भी लिखो, और आपकी प्रोविजनल डायग्नोसिस क्या है ये भी लिखो, ताकि पेशेंट नहीं भी बची तो एटलीस्ट आपके नोट्स में आपने सस्पेक्ट किया था तो आपने एडवाइज ये चीज लिखी है. एवरी वर्ड इन योर डॉक्यूमेंटेशन इज गोइंग टू सेव यू फ्रॉम मेडिको लीगल लिटिगेशन. सो वी हैव अब नहीं, ये अपन सब कर चुके हैं, है ना. हाँ, तो अब हमारे पैनलिस्ट एक लाइन बोलें और फिर हम उसको, हाँ ये मेरी अपील सुन लो. आई एम स्टैंडिंग फॉर वाइस प्रेसिडेंट नॉर्थ. अच्छा लगे तो अपनी वोट दे देना, अपने दोस्तों की दिला देना. बट लेट्स गो बैक टू ये कंक्लूजन है. आई डोंट वांट दिस. आई वांट ऑल द पैनलिस्ट टू गिव वन लर्निंग लेसन or one message that you would like to give. Nidhi, starting with you.
Unexplained breathlessness, do echo. Otherwise, you will miss dilated cardiomyopathy.
Very good. So, Dr. Juhi, हमारे स्क्रीन पे आप दिख रहे हो. आप अपना एक मैसेज दो.
जैसा उनका always anticipate preparedness, prepare your staff. That is more important. Supportive staff management is a prime thing which should be always done in any type of emergency. क्योंकि वो उनको कुछ समझ नहीं आता. जैसे मैडम आपने कहा कि एक्चुअली नहीं समझ आता नर्सेस को, पैरामेडिक्स को, कि what is the importance of doing all these things. So drills should be done and they should be trained, and also pictorial representation of drills should be always pasted in your working space.
ठीक. फिर डॉक्टर मोनिका सिंह आप भी बोलोगे क्या?
हाँ मैडम, मैं ये बोल
बोलो.
रही मेरा तो क्वेश्चन है मैम, कमेंट
अच्छा
नहीं।
तो फिर रुको, अभी पहले डॉक्टर चारू को बोलने दो।
एक
मैं
इम्पोर्टेंट
अपने स्क्रीन में जो इनका आ रहा है ना उनसे पूछ रही हूँ।
We
डॉक्टर
have to
चारू,
be,
योर evaluation, मैम.
ma'am, definitely we have to identify the high risk pregnancy in time so that we can take care, especially in those patients.
So very nice. All high risk patients have to be always we have to be very careful. Dr. Raj Kishori, ma'am.
Ji ma'am, as per the gynecologist, we should be well versed in the BLS training, and we should be knowing how to do the basic life support, and we have to anticipate the high risk patient, and early recognition is of prime importance, and simultaneously we have to resuscitate the patient, and we have to if we are wrong in any place, simultaneously we have to correct, and here the role of the staff is very important. So in this time we have to gather as many hand as early as possible so that we can give the appropriate CPR and other resuscitative measures. Thank you, ma'am.
Good. So Dr. Rashmi. Dr. Rashmi,
In case
Dr.
of
Anju.
breathlessness, yeah, ma'am. In case of breathlessness in patient, we should at least have in our prescriptions a prescribed echo and a physician reference. And second, we should not be scared to use lipids in case of anesthetic complications. At least lipids should be available in our OTs and labor room.
Yes. So I think Anubhuti is not there. Shweta has also gone away. उनके बच्चे छोटे हैं. And thanks to Padma.
Madam, ask one question.
Yeah, please do.
Ma'am, small nursing homes, emergency and amniotic fluid embolism in a second para or a third para. Total आपके nursing home में आप हैं. There is suppose hypothetically your husband pediatrician is there. There are 2 nursing staff and there is 1 cleaner या जो भी आजकल बोलते हैं. We don't call class 4 ना. जो ही क्या बोलते हैं I don't know. उनको हाँ बाई अटेंडेंट जो भी है. अब मैडम ये पेशेंट, this patient collapses within half an hour of delivery. Okay, the baby is all right, baby is safe. Mother collapses within half an hour of delivery. In your labor room, she certifies. Attendants, they create a ruckus. They don't want a autopsy. They are not ready for autopsy. They all make a hangama in your nursing home and people crowd gathers. Now, how will you prove that this is amniotic fluid embolism if the attendants are not signing for autopsy? And how will you
Would
save
you like to take the question?
How will you save yours?
Definitive diagnosis though can only be made on autopsy.
Really, how will Dr. Padma, what I'm worried about is I have stopped my small nursing home practice because of these tensions only. But I was wanting, how will this small nursing home owner of 25-bedded nursing home or 15-bedded nursing home with 4 staff available at the time of amniotic fluid embolism, where the patient could not have been saved probably in GMC Bhopal?
Yeah, I'll tell you what, Monica.
Yes,
यहीं पर ना आपकी जो फॉरवर्ड थिंकिंग है वो हेल्प करती है, और आपके ना टीममेट्स जो हैं, इसीलिए अगर ड्रिल हुई है तो आपका कोई सा भी जना लेबर रूम में लेके आ जाएगा क्रैश कार्ट को. आपके हस्बैंड या कोई भी जना इंट्यूबेट करे. मेरे साथ यही हुआ था. मेरे हस्बैंड ENT, उन्होंने इंट्यूबेट कर दिया था. दे कंटिन्यू टू डू. खैर हमारा पेशेंट दूसरा था, बट लाइक यू सेड, यू आर सिंगल हैंडेड. फर्स्ट थिंग इज कॉल हेल्प. मतलब आपका जो स्वीपर है ना, वो आपके बेस्ट फ्रेंड्स की टीम को बुला दे, IMA को, आपकी सोसाइटी को, तो कि ये आपके ऑलरेडी वर्कड आउट होने चाहिए कि मैं ऐसी प्रॉब्लम में फंसूंगी, कोई भी फंसेगा तो सीनियर गायनेकोलॉजिस्ट, एनेस्थेटिस्ट सब लेके आ जाते हैं. रेवाड़ी में तो बहुत अच्छा टीम वर्क है. किसी के हॉस्पिटल में कुछ होता है, जब आ जाते हैं और उसके बाद
हियर कम्स रोल ऑफ एक्शन एंड डॉक्यूमेंटेशन. आपने अगर सारा सीक्वेंस ऑफ इवेंट अच्छा किया है तो वो कितना ही चिल्ला ले.
डॉक्टर जूही, बहुत इंपॉर्टेंट बात यह है कि अगर ऐसा कैटास्ट्रोफी हो जाए तो हमारा खुद का काम और हमारा ड्रामा ठीक होना चाहिए. तो हमारी टीम्स होनी चाहिए. हमारा इंट्यूबेशन हो गया, हमारे को कोशिश ये करनी चाहिए. वी विल हैव टू डिक्लेयर दैट द पेशेंट इज नो मोर. तो वी हैव टू डू इट एट आवर व्हेन वी आर रेडी टू डील एवरीथिंग. तो जब हमारी टीम होती है, हम 4 जने, मतलब एक आप हो, आपके एक हस्बैंड स्ट्रगल कर रहे हैं और 2 स्टाफ है, तो आपको वो मारेंगे ही। इसलिए ऐसे में हमेशा अपने सारे कोलीग्स को बुला लो, एनएसएस को बुला लो, सबको बुला लो जो आपके टीम वाले हैं, so that you are, there is security in numbers. And
very
once that is there,
ma'am,
try
वो-
to take
yeah.
the patient in a set where you can declare safely, नहीं तो तुम्हारी जान को खतरा कर देंगे। ठीक है
जैसे
ना?
मैडम ने ये कहा ना कि ड्रामा ऐसा होना चाहिए, ड्रामा आपका बहुत सिस्टमेटिक होना चाहिए जैसा आप करना है।
हाँ, इसीलिए हमने बोला कि अभी तो हमने बहुत सारी छोटी छोटी चीजें नहीं बताई। हमेशा आपका लेबर रूम और आपका ओटी में सारे रिससिटेटिव इंजेक्शंस होने चाहिए,
बिल्कुल होने
सारे
चाहिए।
ट्यूब्स होनी चाहिए, सारे कैथेटर्स होने चाहिए, नो पर्ची टू द पीपल आउटसाइड, एंड
बिल्कुल
कोई
सही।
फ्लैप नहीं होना चाहिए एक्चुअली, क्योंकि इतना लंबा हो चुका था मोनिका, so we didn't add it, but I'm glad you brought it, because these kinds of emergencies when they happen, we have to be so much in control कि बाहर वालों को पता भी नहीं चलना चाहिए कि कितनी बड़ी अंदर विपदा आई हुई है। पूरी टीम इकट्ठी हो जाए, सब कुछ हो जाए, और पुलिस को पहले से बुलाओ और पुलिस को इन्फॉर्म करो कि इसका वो होना है। मैं एक केस
Postmortem,
जल्दी से
yeah.
बता देती हूँ। मेरी सिस्टर इन लॉ ने सिजेरियन किया था, और सिजेरियन करके वो एक्चुअली उसका हाई रिस्क, अगर अपन रेट्रोस्पेक्ट में देखते हैं तो वो हाई रिस्क प्रेगनेंसी थी, वो बेड रेस्ट पे थी। उसका सिजेरियन हुआ, बड़े आराम से बच्चा पैदा हो गया। उन्होंने मिठाई तक बांट दी। 4 घंटे के अंदर अंदर रूम में ले जाने के बाद पेशेंट हैड pulmonary embolism, DVT pulmonary embolism. That's what I think. They shifted her to the ICU. They started intubation and everything, but she started oozing from the skin side. So they opened the abdomen, and I got a call when they had opened the abdomen the second time. मतलब पहला सिजेरियन में मैं नहीं थी उस टाइम, इन्होंने मेरे को बोला, तो उन्होंने कहा सिर्फ डार्क ब्लड है, इट वाज लाइक DIC। ठीक है ना भाई, आप करते तो हो ही। उन्होंने कर दिया। दो क्लोज अप वो vasopressors पे थी। She was shifted into the ICU, and because I was the senior most person, I told my brother and his wife and everybody, the anesthetist, the surgeon, let's prepare the notes because this patient will not survive. अभी हम अपने कागज पूरे कर लेते हैं और ये 3-4 घंटे निकालो। और सबके नोट्स देवर मैचिंग। ये नहीं कि सर्जन कुछ लिख गया, एनेस्थेटिस्ट कुछ लिख दिया, ऑब्स्टेट्रिशियन ने कुछ लिख दिया। तो मेरा काम तो सिर्फ मॉनिटरिंग का था। मैंने रिकॉर्ड्स ठीक रखवाए और टाइम टू टाइम रिलेटिव को बुला के उस रूम में दिखाया कि वी आर ट्राइंग। गुड थिंग वाज कि वो कैमरा नहीं होता है, उसमें मिठाइयां बंटने वाली रिकॉर्डिंग थी कि शी वाज फाइन। यू अंडरस्टैंड? फिर उस पेशेंट को जब मॉर्निंग टाइम में पुलिस को पहले इन्फॉर्म कर दिया था, तब हैंडओवर करने से पहले उनसे कहा कि पोस्टमार्टम जरूर कराओ, नहीं तो पता नहीं चलेगा। तो काइंड ऑफ दे अग्रीड, और पोस्टमार्टम में ऑफ कोर्स करने वाले बहुत ही निहायत महान होते हैं। they don't actually find out the real cause, but because circumstantially everything fitted and the documents were complete, तो इंक्वायरी के लेवल पे ही मतलब we could kind of contain the medico legal litigation. Otherwise it's teamwork. मतलब जान तो भगवान बचाएगा अगर जिंदगी है, पर डॉक्टर को तभी बच सकता है जब अपन ने ये सिनेरियो ना मल्टीपल टाइम्स कर रखा हो।
अभी मैम भोपाल में देयर इज अ तत्काल ग्रुप में देयर इज अ व्हाट्सएप ग्रुप, ऑल नर्सेस। as soon as there is call for help on tatkal, about 25-30 doctors they rush there without asking reason.
हाँ, उसमें भी मोनिका बिल्कुल सबको पता होना चाहिए क्या करना है, सबको पता होना चाहिए। नहीं तो आजकल मरीज बहुत समझदार हैं, तो बहुत ज्यादा भीड़ होती है तो भी वो लोग दे मेक
Suspicious
मोर
हो जाते
रकस,
हैं।
क्योंकि वो 20 को तो 200 करने में उनको तो 5 मिनट लगते हैं। तो यहाँ आपका जैसा केस है ना, उस हिसाब से अगर आपके हॉस्पिटल में तोड़फोड़ हो रही है तो 20 बुलाओ, पर अगर आपके हॉस्पिटल में ऑब्स्टेट्रिक इमरजेंसी है तो सीनियर ऑब्स्टेट्रिशियन, सीनियर एनेस्थेटिस्ट, सीनियर कोई भी एक आ जाने, मतलब बड़े फोकस्ड लोग होने चाहिए। मतलब आई
मैडम ने एक बात बहुत सही कही कि हर जगह हर चीज रखिए। आप ये नहीं कि मैं ये ढूंढ रही हूँ, एक ट्यूब, एक स्टाफ जा रहा है वो ट्यूब ढूंढने जा रहा है, उसको मिल नहीं रहा है, वो हड़बड़ी में है।
ये जो एक्रेडिटेशन हो रहा है आजकल, NABH मान्यता, द फर्स्ट थिंग दे चेक इज योर किट्स. They will not check the OT. They will show us your emergency drugs. Show us the expiry date.
बिल्कुल।
आपकी एक एक्सपायरी हुआ तो वो आ जाता है उसमें एनसी में, नॉट एनसी आती है ना मैडम,
हाँ,
एनसी आ जाती है,
नॉन कंफॉर्मिटी
अनकंफर्म
that it is
एनसी आ
wrong.
जाती है, 80 100 एनसी आ जाती है।
हमारा अभी दोबारा हमारा हो चुका है, अब हम NABH की दोबारा से कर रहे हैं,
मैडम
मतलब
हम तो एंट्री लेवल कर जाते हैं क्योंकि फुल एनएबीएच तो इतना मुश्किल है मैम, फुल एनएबीएच करना।
हमारा फुल NABH है और अब उसका
हाँ।
सेकंड वो असेसमेंट होना है फिर से,
नहीं,
मतलब
फुल
रिन्यूअल करना है हमें।
अगर फुल एनएबीएच है इन प्राइवेट स्पेस, इट इज हैट्स ऑफ टू यू मैडम।
एक फाइल में 25-30 पन्ने होते हैं,
Yeah.
आफत है।
Yes.
चलिए, so I think we have completed, everybody had a fill of डॉक्टर चारू आपने बता दिया था? हाँ, डॉक्टर चारू ने बता दिया था।
Madam, it was a really nice panel. I've never heard such a dynamic panel ever.
अरे नहीं, ऐसी बात
And
नहीं है।
his contribution and all the panelists were extraordinary. It was all real life case scenarios and very, very enjoyable, madam. मेरा तो पूरा
मैडम मजा आ गया।
obstetric
Thank you so much. Yeah, thank you so much, ma'am.
मैम, ये हमारी चारू बहुत अच्छा गाना गाती है। She's a
प्लीज
national.
एक गाना हो जाए।
Thank you, ma'am. Wish you all the best.
लाइनें सुना दो।
चारू दीदी अपने टाइम की टॉपर है भाई, बड़ौदा की।
चारू 2 लाइनें सुना देते लास्ट गाने पे, इतनी मीठी आवाज है। सुना
Oh God.
प्लीज प्लीज।
तेरे बिना जिया जाए ना, तेरे बिना जिया जाए ना, बिन तेरे तेरे बिन साजना, सांस में सांस आए ना। ओ थैंक यू।
ओह वेरी नाइस,
Very nice.
चारू आप तो कमाल हो।
गाना एम्बोलिज्म का गाना है, सांस में सांस नहीं आ रही है।
चलो, वेरी नाइस, ओके। सो
Thank
डॉक्टर
you.
जूही,
Thank
आप
you,
मुझे
ma'am.
वो यूरिनोमीटर भेज दीजिएगा फोटो। हाँ निधि,
थैंक मैडम, बेस्ट विशेस मित्रा मैम, थैंक यू।
थैंक यू,
बिल्कुल।
Best
Ma'am,
wishes,
I'll
ma'am.
send.
All
I'll
the
send, ma'am.
best.
Thank you, ma'am. Thank you.
आप
Thank you
सबका
for
साथ
making the
चाहिए मुझे।
Sure, ma'am.
थैंक यू,
Sure.
हैड अ नाइस डे।
Thank you,
थैंक
ma'am.
यू सो
डॉक्टर
Thank you
जूही,
so
आप
much.
सब तो, डॉक्टर चारू आप लोग तो मेडिकल कॉलेजेस में हो, आपकी तो लंबी लिस्ट है, आपके साथ आपका परिवार है जिनको आप वोट करा सकते हो, तो
Sure,
प्लीज
ma'am.
मेरे को
Sure.
मैडम
support
आपके
करिएगा।
जैसे लोगों को तो आना चाहिए आगे।
तो
बिल्कुल।
आप लोग लाएंगे तो आ जाएंगे, whatever God wants।
Why is
बिल्कुल।
motivated voting? Juhi, the voting percentage is very less.
हाँ, आप
Foxy,
लोग
out
को
of
MP से इस बार बहुत सारी वोटें दिलवानी है, क्योंकि MP इज वन स्टेट आई एम वेरी वेरी फॉन्ड ऑफ। इंदौर वालों ने मेरा, मतलब सभी लोगों ने, आपने MP से बहुत चेयरपर्सनशिप में भी हेल्प किया था, अभी भी बहुत पॉजिटिव वाइब्स हैं, एंड ऑफ कोर्स आई बिलीव इन गॉड्स जजमेंट।
नहीं मैडम,
Sure,
आप
ma'am.
work is showing, it is visible, and MP definitely will support you. मेरा
थैंक
तो खैर प्राइवेट सेक्टर ज्यादा है, बट जूही एंड ऑल आर इन मेडिकल कॉलेजेस, दे कैन, यू नो, चारू कैन कवर ग्वालियर।
आप लोग करो भाई
I
प्लीज।
can cover Gujarat also.
ओ
हाँ, ये
चारू
तो
प्लीज
ये तो
करिए।
गुजराती है।
चारू
मैरिड
मुझे
टू
बताइए
मेडिकल।
आपको कैसे ब्राइब करना है।
Not at all, not at all, Neeran ma'am.
गाने
I have my
सुनूंगी मैं तो
students
भाई।
over there. I have my
जूही का
students
तो
over
वही
there. So
कॉलेज है,
I will.
अहमदाबाद एयर इंडिया वाला कॉलेज है जूही का।
नहीं,
हाँ, मेरा
yeah, she was there. I remember. I
Yeah.
was from Baroda, so I will definitely drop a word
दीदी
with my
बड़ौदा
students.
की है, मैं आई डिड फ्रॉम अहमदाबाद।
Yeah.
Thank you, thank you.
Thank you so
I
much.
just
Okay,
believe
ma'am.
one
Thank
line of
you.
recommendation is good enough. You know, लंबी चौड़ी
Definitely.
कहानी से नहीं होता। एक अब जैसे अब आपके जो टीचर कह देते हैं कि नो शी इज गुड, दैट इज गुड इनफ फॉर द स्टूडेंट्स।
True.
ठीक है ना? तो थैंक
मैडम
यू
आपकी
मोनिका।
खूबी ये है
Okay,
कि यू आर
thank you.
वेरी नेचुरल, बहुत नेचुरली आता है ना मैडम का हर चीज। मित्रा
Down to
मैम
earth.
वेरी
She's a
सही है।
teacher and a
आप
true
सब बड़े
convert.
टैलेंटेड हो। ओके बाय बाय,
So
गुड नाइट।
Okay.
Good night,
just
everyone.
थैंक यू
Good
मोनिका
night.
दी,
थैंक यू
थैंक
पद्मा, आई हैव
अरे
टू
नहीं
थैंक
नहीं
हर।
नहीं
thank
नहीं
you. A
मैम, very
formal
great
vote of thanks to
thank you.
everyone present, to all our faculty, to all our delegates, experts, panelists, chairpersons. Thank you, Dr. Vishal, for staying there 4 hours. And thank you, Team Intas. Please stay tuned for our next webinar in August. 7th August is proposed, and this is Breast Week. So we will be dealing with diseases of the breast and screening for breast cancer and so many other things. Thank you so much. Have a great week and
यू
weekend.
मोनिका दीदी, थैंक
थैंक
यू।
यू चारू, योर सॉन्ग वाज वेरी ब्यूटीफुल।
Best wishes, ma'am.
थैंक यू।
Bye. Bye. Good night.
Thank you,
Good night.
Rajkishori. Thank
Support team, please end the
Thank you
meeting.
so much, ma'am.
Thank you.
Support team, end the meeting.